Good evening, distinguished faculty, dear colleagues, researchers, and all the delegates. It's my great pleasure to welcome you all for the 7th Best Clinical Oncology Symposium 2026. Thank you for the joining us as we come together to review and discuss the most important advances that are shaping the future of cancer care. So today's symposium is day 2 and it has been carefully designed to highlight the top picks of 2026, the studies, clinical trials, and emerging concepts most likely to influence everyday oncology practice. So day 2 focuses discussions on cancers like lung cancers and breast cancer. And once again, I welcome you all for this very interesting academic feast. Thank
So
you very
thank you
much.
so much, Dr. JB Boss. Thank you so much, Dr. JB Sharma sir and Dr. Somani sir for executing the 7th BCOS, right? And we have a pleasure to start the discussions for today. And it's a great pleasure to welcome and invite Dr. Vikas Talveja. Sir is a consultant medical oncologist and hemato-oncologist at the prestigious Regency Health Center at Kanpur. So once again, ladies and gentlemen, good evening to you. And so over to Dr. Vikas to you for your presentation.
Thank you, Tarun, for the honor, and thank you, Dr. Sharma sir and Dr. Somani sir for invitations. It is definitely an intellectually awakening agenda so far now, and I am the opening best end, so I will request the team to share slides on my behalf, if it is possible. So we'll start with the ESCO updates that has revolutionized the way we treat many of the cancers, and I believe it's going to be a game changer in a Monday morning practice because they have been selected in a great manner, specifically the topics that we will be discussing in next 20 minutes. So the first trial I will discuss will be the Liberator trial, where the event-free survival with adjuvant selpercatinib was seen in stage 1 and stage 3 RET fusion positive non-small cell lung cancers. Next slide. So the key takeaway was that we know that in metastatic situations, RET positive selpercatinib does improve the overall survival, and that was also seen in early stage lung cancer. And safety profile was consistent with the metastatic situations, and it now shifts the adjuvant therapy in terms of ALK and the EGFR testing. I believe RET testing should also be done for all patients in lung cancer in adjuvant situation. Next slide. So if we look at the data in terms of why it was selected, because we know that the RET positive populations perform poorly in adjuvant situations. And as we are shifting towards the targeted therapies, more and more targeted therapies are coming from metastatic situations in an early situations. And this was where the Liberator 431 trial was being designed. Next slide. As it shows that in those patients with RET positive non-small cell lung cancers in stage 1B to 3A, where the chances of recurrence occurs nearly 70% after the completion of the curative intent of the treatment. The selpercatinib was given in dose of 160 milligram twice daily for more than 50 kg patients, and less than 50 kg patients 120 milligram twice daily up to 3 years. And the primary endpoint was the EFS, and the secondary endpoints was the overall survival, and the independent committee review EFS. Next slide. And it was based on the hierarchical testing that if the primary EFS population, the hazard ratio crossed 0.5 after a planned events of 67, then only they will go. Otherwise, it will be a stop testing. And this was based on assumptions that in terms of osimertinib, it was 0.17. In terms of alectinib, it was 0.24. And that's where it is going to make much more difference. Next slide. So overall, the population was distributed across 151 patients in 65 sites across 22 countries. And from January 2020 to March 2025, the data was cut off in January 2026 and was released in the ASCO this year. Next slide. If you look at the primary baseline characteristics, it was equally matched. And in terms of what was key highlights was the what red testing was done was the KIF5B red fusion was seen in 60% of the patients, and the CCDC6 was seen in around 25% of these patients. So these are the most common two fusions that are seen in lung cancer, not the thyroid ones. These are different from the thyroid ones. And most of them did have some form of PDL1 positivity also. So 50% of them did have a PDL1 positive in the population. So next slide. As you could see, in terms of the primary endpoint, it was significant in terms of hazard ratio being 0.172, meaning nearly 80% reduced chances of progression in stage 1 to stage 3 patients with 2-year EFS crossing 91.5% with selpercatinib as compared to placebo, where it reduced to 60%. So next slide. And similarly was the investigator assessment PFS and EFS in selpercatinib with 74%, 84% reduced chances of progression of events in those who were given selpercatinib as compared to the placebo. Next slide. If we look at the independent committee review, you could see similar results, in fact, better than the investigator assessment. So nearly 88% reduced chances of events in those who had a selpercatinib as compared to those who were kept on the placebo arm. Next slide. And all the subgroups demonstrated beneficial effects. The never smokers were the highest who got the maximum benefit. And irrespective of age, performance status, whether the prior chemotherapy was given or not, the benefit was seen across all subgroups. Next slide. So when the progression was seen as seen in the placebo, it's most commonly the distance progressions, that's nearly 18%, and out of them 3% were brain progression in the placebo arm, while in selpercatinib only 1% was seen as the brain progression, and the local regional progression was also 1%. So quite great figures in terms of the sites of the progression also. Next slide. And if you look at the follow-up period, again, it's a 2-year follow-up period, and most of the patients are on treatment on selpercatinib after that also, with no report, there are no deaths occurring in the selpercatinib arm as compared to 3 in the placebo arm. Next slide. If you look at the events of interest in terms of what was reason for the selpercatinib discontinuation, it was most commonly the laboratory, that includes the AST, ALT elevations, and then there is an interstitial lung disease incidence also. Next slide. Most of the time, as I said, AST, ALT increase, diarrhea are the common side effects with the selpercatinib, but not leading to grade 3 or hospitalization. And QTC needs to be monitored specifically in those who are having selpercatinib as compared to the placebo. Next slide. So to conclude, with hazard ratio of 0.17, reduced chances of progressions, the selpercatinib has been approved in terms of the FDA, NCCN, and the various guidelines after this data as a standard adjuvant therapy in terms of red fusion positive stage 1 to stage 3 non-small cell lung cancers. And it reinforces the value of comprehensive biomarker testing for all patients in those in adjuvant situations, which has become a standard of care. Next slide. Next slide. Next slide. Next slide. So next comes the Harmony trial, where in those who have an advanced squamous non-small cell lung cancer, ivanatinib plus chemotherapy versus tislelizumab plus chemotherapy was compared. Next slide. So Ivosidenib is the first molecule that is a combination of a PD-1 and a VEGF inhibitors, and it has been there in China for a long time, and it has come in the European and the American trials in recent. So ivosidenib is, to layman, it's a combination of pembro plus avastin combination sort of therapy, and it was compared in direct head-on treatment with the uh, chemotherapy plus immunotherapy, in which is the standard as an advanced squamous cell non-small cell lung cancer. So next slide. And Harmony is the first trial comparing the ivosidenib with chemotherapy versus tislelizumab plus chemotherapy. And if we look at the uh, Chinese data, where it was seen that there is a significant improvement in the PFS from 6.9 to 11.1 months, and that's where they are reporting now the overall survival data for the same. Next slide. So this was the trial design. Ivosidenib given in 20 milligram per kg every 3 weekly with the paclitaxel combination every 3 weekly, as compared to tislelizumab given every 3 weekly with paclitaxel given every 3 weekly for squamous non-small cell lung cancers not harboring EGFR ALK mutations in a metastatic situation, stratified based on the stage and stratified based whether they are PDL positive or negative, and the maintenance of ivosidenib versus tislelizumab in both the populations, with the primary endpoint being the PFS and the secondary endpoint being the overall survival. Next slide. So again, the hierarchical testing was done, that when the first uh, PFS events were being analyzed, and if they have seen a one-sided alpha of 0.025, then only they would analyze for the overall survival. And since the PFS was statistically significant at the interim analysis from 6.9 to 11.1, they present the OS data right now. Next slide. Next slide. So around 500 patients were randomized, baseline characteristics exactly matched, with the PDL1 score being balanced in both the groups. So PDL1 positive being around 42% and metastatic site being equally distributed, including the brain metastasis stable patients, and including they have categorized as many of times there a central or a major blood vessel encasement or a cavity or hemoptysis history where you have a fear of using anti-VEGF molecules upfront. Next slide. And as expected, with the pre-FS benefit comes the overall survival benefit, also hand-on, and nearly 33% reduced chances of death from 23.69 with the chemo plus immuno combinations now to the chemo, immuno, and the anti-VEGF options. And this was the first time they dared to enter in the squamous market, and they entered with a double combination. So again, showing that in 2 years, 65% of the patients were surviving in the ivosidenib with chemotherapy combination as compared to tislelizumab with chemotherapy combination. Next slide. And if we look at the subgroups which benefited, again, irrespective of whether they had a cavitatory, major blood vessel encasement, hemoptysis, where the risk of bleeding was high, they had significant benefit in terms of nearly 40 to 50% reduced chances of deaths. So next slide, showing that all across the subgroups, irrespective of the PDL1 expressions, the ivosidenib plus chemotherapy showed consistent overall survival benefit. Next slide. Next slide. And most of those patients where ivosidenib plus chemotherapy failed, then they were given the options of chemotherapy subsequent lines or a targeted therapy or an immunotherapy. And some of them were given even traditional Chinese medications. So most of these patients tend to receive second line of therapies with uh, nearly 266 of these numbers in either of these arm. Next slide. And as you see, the safety profile was manageable. 69% of the patients developed some form of grade 3 treatment-related adverse events, with 41.4 developing some form of serious treatment-related adverse events, and 3.8% led to the drug-related deaths in the ivosidenib arm as compared to 4.2 in the tislelizumab arm. Next slide. So most of these side effects are chemotherapy induced. So pegcilcarbo causing anemia, alopecia, neutrophil, uh, proteinuria, platelet count, hyposthesia, decreased appetite, AST, ALT, elevations, and tislelizumab causing hypothyroidism. Next slide. And the VEGF-related side effects includes the proteinuria, hemorrhage, hypertension, arterial venous thromboembolism, did increase in the ivosidenib arm, but none leading to a grade 4 side effects. There were grade 3 proteinuria, hypertension. Next slide. So to conclude, the first trial to show a combination of VEGF plus PDL1 in an advanced squamous non-small cell lung cancer with an overall survival going up to 30 months as compared to 24 months with the chemo plus immuno, which is the current standard. And it's supposed as a new standard of care in first-line treatment in China with the Harmony trial going in the same way. And as you could see, the safety profile matching with the consistent standards. Next slide. Next slide. Next slide. Next slide. So next slide. So the Libretto getting NEGM publication and the Harmony getting Lancet publication was not unexpected because of the brilliant results. Now comes another breakthrough, specifically when we are confused with what to do in those patients who have non-traditional EGFR mutation, and there come the combination of amivantamab plus lazertinib, the updated results from the Chrysalis study. Next slide. Again, we know that most of the patients do tend to have a less frequent exon 20 insertions and atypical mutations, which harbor a whole gamut of various uncommon mutations. So not exon 19 or not exon L858R, which are the traditional mutations where the TKIs are known to work. So you have an EGFR mutation, but you don't have an traditional mutations, and you're confused as what to do for these patients. And that's where the Chrysalis 2 study was carefully designed in this atypical mutation subset. Next slide. And as we know, amivantamab has been the hero in the latest in terms of the Mariposa trials, where it has shown that in second line and in the first line, the combination has shown better than the osimertinib combinations, and it is a dual um, mechanism of action, including the EGFR and MET inhibition, and as well as the ADCC activity that it has. So it has been approved in EGFR and exon 20 mutations. So next slide. So this was the basically the cohort C of the Chrysalis study in the dose expansion cohort. And it included treatment naive as well as those patients who have prior received some form of EGFR therapy or some form of chemotherapies. And those patients where exon 19 deletion and L858R co-mutations were present were excluded from the study since the standard have been there. And all those patients from the Cocoon study or the Skipin study or the Paloma study were allowed to include in the Chrysalis study. So the next slide. Amivantamab as the standard dose has been 1050 for more than 80 kgs. With lazertinib, that's not Indian available, but you can consider that as a competitor for the osimertinib. So if you look at the swimmers plot again, you could see brilliant responses going up to 57% of the population with a median follow-up of 16.1 months, and the duration of response going up to 21 months with the median progression-free survival going up to 20 months, with the upper limit not being reached in these patients who had a treatment naive, atypical EGFR mutated non-small cell lung cancer enrolled globally. Next slide. Next slide. So if we look at the overall survival also of these patients, So 20% of the patients were still going on the first line treatment, and 7 patients were continuing on amivantamab plus lazertinib. And next slide. If you could look at the overall survival, it is astounding at around 40 months of the overall survival with the combination of amivantamab plus lazertinib, with nearly 55% of the patients crossing the 3-year mark, and those who are crossing the 3-year mark are also crossing the 5-year mark also. So possibly we will be looking up for a more updated overall survival in next ASCO for the same, because so far the follow-up period has been around 30 months for now, and it has been an estimated overall survival for 41 months with an upper limit not being reached and lower limit being around 30 months. Next slide. And when they progressed, most of the time, some form of oral therapies, which includes the TKIs like afatinib, osimertinib, catechinib, or rusortinib, was being given. Some form of chemotherapies, which includes pemetrexed, carboplatin, PEMSIS, or PEMSIS-Bev, or ABCP form of regimen was being given. Next slide. So all form of combinations being tried, but yes, you could see with that uh, curve, I believe 40% of the patients living more than 2 years with the first combination of uh, amivantamab plus lazertinib shows a remarkable response, irrespective of whether they had a CNS disease, irrespective of whether they had a geriatric population, or the geographical being an Asian subset where it is said to be dismally performed as compared to the European or the American subset. Next slide. If we look at the local data also in terms of what mutations was there or what was the compound mutations, you could see that irrespective of it, it is performing uniformly well across. And specifically in those who have a compound mutation, the data is quite great. Next slide. Next slide. So those patients even having a TP53 co-mutation type also showed a good response. And when it was retrospectively compared with the real world cohort of the atypical EGFR through various network analysis, it was seen that around 15 months was on an average first line treatment, whether you give an osimertinib, whether you give an some form of afatinib. So all those atypical EGFR.
Apologies, sir. Request you to conclude your presentation.
Perfect. So last slide only. So next slide. Next slide. So safety has been known for this, and this study demonstrates the first time the amivantamab plus lazertinib combination with around 50 patients having an atypical EGFR mutated in a randomized single arm study. So I believe the responses were durable, and regardless of demographic baseline tumor mutations and disease characteristics, this shows great responses. So I conclude here for now and will hand over to the organizers and would love to answer any questions if there are any.
Thank you, sir. Thank you for the excellent talk. So, any questions? Or we move to the panel discussion so that which is on the same abstract side. Yes, sir. Dr. Naresh Somani, sir, any questions or we should start the panel, sir?
Please go ahead with the panel.
Okay. So, I would like to invite Dr. Vijay Agarwal, Professor and Lead Consultant Medical Oncology at Apollo Hospital, Bangalore, for the panel discussion on Topics ESCO 2026, and would request sir to invite the panelists, to call upon their panelists.
Thank you.
Over to you, sir. Yeah.
Thank you very much for the introduction, and thank you, Dr. Sharma and Dr. Naresh Somani, for asking me to cover this important topic for discussion. These were some of the abstracts that were presented in ASCO, which are quite exciting to look at, especially the top two plenary sessions, the Harmony 6 and the Libretto 432. But can I please ask my panelists to see if they're all there? Dr. Satya Sarangi, I saw his name there, so he should be there. Dr. Ankit
Good evening,
Agarwal,
sir.
good evening. Dr. Ankit Agarwal from Udaipur.
Hi, good evening.
Dr. Jovita Martin from Chennai.
Good evening, sir.
Dr. Rashmi Bansal from Delhi.
Yes, sir, I'm there.
I couldn't see Dr. Ravi Jaiswal from Raipur. Is he there?
Sir, he's joining shortly. Yeah.
He's joining shortly.
Yes.
Okay. Just ping me when he joins. But welcome, Dr. Satya, Dr. Ankit, Dr. Jovita, and Dr. Rashmi. We'll go through these four, but I think we'll spend most of our time with the first two because they were the plenary sessions with kind of the most impact in our clinical practice. The other two we'll skim through a little bit. So we'll start with the Harmony 6. We won't go through the data as Dr. Talreja has already been through all of these data. But the important thing is to look at ivonisimab plus chemotherapy versus trastuzumab plus chemotherapy to see how it kind of impacts. Ivonisimab has been approved in China for the past couple of years, and they have treated a lot of these patients. We know that IVO is a bispecific antibody against both PD-L1 and VEGF inhibition, and that has significantly improved both progression-free survival as well as overall survival in the first-line squamous cell lung cancer setting. I think we've all been privy to this data, so I won't go through the data again. But let's start with Dr. Satya. What do you think of the comparator arm in this study? So they used the comparator arm of Tesley with chemotherapy. And how does this fare with the Indian practice setting? What are we used to in our first-line squamous cell non-small cell lung cancer? Small cell lung cancer, squamous cell lung cancer. Dr. Satya?
Yes, sir. So I think as of now, means from previous years, we are more dependent on, I think, pembrolizumab plus chemotherapy, or maybe Nivo plus EP plus like the Checkmate 9LA trial, or maybe the ABCP trial. So we have been using these regimens more frequently. But recently, with the available of this cheaper immunotherapy in the form of tislelizumab or serplulimab, now more and more we are including more patients on these regimens where there is a cost constraint. But overall, if you ask me my opinion on the data, I feel it's a good option to be considered as a comparator arm.
So clearly the IVO plus chemo is significantly better compared to Tisli and chemo. The question here is Tisli interchangeable with all the other PD-L1 inhibitors? For example, we use hormone therapies like letrozole or estrozole interchangeably. Can we now start using PD-L1 inhibitors interchangeably because we don't have comparative data of one of the other? So if A arm, for example, if IVO plus chemo is significantly better than Tisli plus chemo, can we automatically presume that it is better than all the other PD-L1 plus chemo, PD-L1 inhibitors plus chemo? And I think that is the question that we kind of don't have an answer to. But I guess given the significant difference in both the progression-free and overall survival, it would be difficult to ignore them. So, Dr. Ankit, what is your viewpoint on the thought of VEGF inhibition in squamous cell carcinoma? We've always stayed away from VEGF inhibition, like bevacizumab or lenvatinib or any of these from squamous cell carcinoma purely because of its cavity-like lesions, central lesions, risk of hemorrhage, and so forth, and hemoptysis. But this is a bispecific antibody inhibiting both VEGF and PD-L1. Are you worried at all, or you look at data as a space value?
No, I think the concern for me still remains regarding VEGF inhibition in squamous cells, especially if my patient has a centrally located tumor, patient is elderly, patient has history of hemoptysis. I think I'll still be concerned in using a VEGF inhibition in squamous malignancy. The trial had used a VEGF inhibitor, the bispecific, and they have proven that it is much better than the standard Tisle plus chemo. But for me, I still have concerns in using VEGF inhibitor in squamous. I think I'll be very skeptical in using VEGF inhibition in squamous, especially if the patient is high risk of hemoptysis or bleeding.
Yeah, I think the tricky part would be if the patients present with hemoptysis.
Yeah, absolutely. History of hemoptysis, I think that will be more worrisome, or probably we will not be using VEGF inhibitor.
So that makes it more tricky. Yeah, and of course, In the Indian context, we have patients with tuberculosis, cavities, and stuff like that. So it does become very, very tricky and plus over the past 10, 15 years, we've been taught, repeated by our teachers that we got to be careful about VEGF inhibition in squamous cell carcinomas and so forth. So I think it will take some more confidence, some more learning, some more experience to start seeing whether we can look at giving VEGF inhibition in squamous cell carcinomas. So, Dr. Jovita, what is your viewpoint on either of these two, either the comparator arm or the VEGF inhibition?
So good evening, and I thank you for having me in the panel. So actually, just as Dr. Satya said and everything, TISI and chemo happens to be a very good duo in terms of having a cheaper IO combination. So that's something which is definitely a good, answer to this. And with respect to the VEGF, just as you previously, mentioned about the concerns of, having a VEGF inhibition, especially in squamous when there's so much risk of hemorrhage. I think I would really think, in this. But then the fact that VEGF with a PD-1 combination is going to actually increase the T cell expression and also probably activate and enhance the PD-1 action. So that would be probably the reason why they're exploring into this. And I think it's, if it translates to a very good, result, I think over a period of time, we'll also be changing and incorporating this in our practice.
No, I agree. I mean, if you look at their own inclusion criteria, they did have a lot of patients with hemoptysis. If you look at about almost a third of the patients, let's see, let me point it out. There's a pointer. A third of the patients here had hemoptysis, history of hemoptysis. So they're quite brave to include them into the trial. And of course, major blood vessel involvement, central types, all of these things are there that we typically see in with the squamous cell carcinoma, and they were still part of the recruitment there. So the other thing what they did was in this group of patients, they took not just patients who were resected, but also patients up to stage 3, who had who were non-metastatic, stage 3. Would you consider this in those patients, or would you be pushing for radiation? Dr. Ravi is joined now. Dr. Rashmi?
Yes, sir. Can you repeat your question? I was not.
Now, so this study also took patients with stage 3 and stage 4 malignancies. If you look at the stage 3, not sure whether they're giving the breakup here. Yeah, stage 3. Stage 3
Yes.
were about 8% or 7.5%, 8%.
Yes.
Would you be pushing for this combination, or would you still consider giving them radiation and then waiting for metastasis?
So both choices are okay. We can use radiation also. We can use the surgery followed by adjuvant chemotherapy also. I think that should be that should be decided by surgeons and radiation.
Fair enough. Fair enough.
Yeah.
And of course, what about the PDL1 status? Would you consider this regimen for PDL1 negative patients?
So in PDL1 negative patients, I am not confident right now to use this combination because as Dr. Zovita was saying, uh, what mechanism of action they have is VEGF inhibition. They turn the immune cold environment into hot environment.
Mm.
That is the logic behind that. And if PDL1 is negative, I don't think it would work.
I mean, this study, of course, had 40% of the patients who were PD1
Yeah,
negative.
yes, definitely, sir.
And then they showed the benefit. But I think something to keep in mind. Clearly, the interim analysis, this was a pre-planned interim analysis, not just any interim analysis, looking at overall survival. And as with most chemotherapy, you see that at the end of...
Dr. Vijay Agarwal, request you to open your video, sir.
hang on. I have to come off the... How do I do that? Can you do that? Okay, hang on. Yes. Can you see me
Yes,
now?
sir. Yeah. Yes, sir.
So when you look at the overall survival, you can see that the curve splitting at 6 months, and the overall survival is quite impressive with the hazard ratio of 0.66. So it's not a number that I think one can ignore, irrespective of the tumor characteristics or the inclusion criteria for this group of patients. And I think one can argue that TISLI plus chemo as a baseline can be a class effect. and IVO plus chemo can be significantly better, better in this group of patients. So I think this is good data. Can I go back to Dr. Satya as to what do you interpret of the overall survival in this study? Dr. Satya? Move to Dr. Ankit. Dr. Ankit, are you there?
Yeah, I think I totally agree. It's a good data. This type of hazard ratio, a 34% reduction in the risk of death, definitely cannot be ignored. But I think we need more time, probably 2 years follow up, and then we'll be in a better position to take a call about the use of anti-VEGF. I think in commerce.
Yeah.
Just few concerns. Probably time will answer our questions regarding the long-term toxicity also.
I agree. I think when you start looking at the tail of the curve, particularly the pink curve, you can see this sharp drop happening at the end of after 27 months.
Yes.
But the question is whether these two curves then eventually meet or not. So longer follow-up will really help. Plus, this is a single country study, looking at studies in China. So waiting for the Harmony 3, which is a more global study, will certainly help us. These are some of the subgroup analysis and the PDL1. I think we won't dwell much on this. I'll just come back to safety. Safety signals. So clearly the ivosidenib arm clearly had slightly more toxicity in compared to the tisli plus chemo. But I think what is more interesting is to start looking at the VEGF related toxicity. So if you look at hemorrhage, proteinuria, any grade, it was significantly higher in the IVO plus chemo arm as opposed to the tisli plus chemo arm. But however, the grade 3 was not that high. Clearly, still higher than the tisli plus chemo, but not that much high that we are not aware of or we can't deal with. So if you look at proteinuria, hemorrhage, hypertension, which are the typical ones that we see, any grade was quite high, but grade 3 was about 6.8% of proteinuria, hemorrhage was 2.6%, and hypertension was 3.8%. Coming to Dr. Jovita, what do you think of this toxicity, particularly any grade versus the grade 3? Would you, knowing the grade 3 toxicity from IVO now, would you be more confident in trying this in your patients in this commercial group?
Actually, honestly speaking, I'm not very confident, sir, looking at the data because especially when it comes to older people, I don't think that I would be very confident. I would wait for some of my friends to actually use it, and I want more data before I become comfortable.
Fair enough. Why dive in first?
and moreover, more than 65 years of age, the hazard ratio was 0.93, if I remember correctly.
Yeah, you're right. I skipped that part because I actually didn't think that was very relevant.
Yeah, but it was subgroup analysis, definitely. So I don't
So
know.
one good thing that Dr. Jovita brought out was actually this study had a cutoff of 75 years. People above the age of 75 were not part of the study, which is apparently some rule in China that happens. I'm not entirely sure why. But yeah, I mean, a lot of the elderly patients will have comorbidities, will have hypertension, proteinuria because of diabetes and things like that. And it does become complex and confusing if you're adding in a VEGF in this group of patients. So I take your point that we should be more careful. We should wait for other people to share their experiences. And I think, given that this has been approved for over 2 years now in China, I think we should start getting some real world experiences. Really, the company that launches this, we should be able to get some real world experiences so that we know what's happening on the ground. So this is to conclude, and I think I just will conclude that I think the Harmony 3 is underway. The recruitment is now over. It's a global phase 3 study looking at this in both adeno as well as squamous in multiple countries. And I think most people will probably wait for that breadth of experience before jumping into this. It is currently not available in India, but even if it did become available, I think we need to be cautious before using it. So I'll just leave this study with this thought that is this a really chemo immuno improvement study or beginning of a bispecific IO? And I truly believe that this is the beginning of a bispecific IO era where you have immunotherapy now combined with VEGF and various other receptors going forward. And I think it'll be an interesting time for us when you can custom design a drug which inhibits multiple receptors. And I think this was going to blow up in lung cancer more than anywhere else. So coming to the next plenary session in the ASCO, which was the Libretto 432 trial, which is probably the most practice changing for us in our practice. Dr. Talrija already discussed this trial, so I won't go into the details of discussing this trial. But this was to look at adjuvant silpacatinib in stage 1B3A RET fusion positive non-small cell lung cancer. And clearly, silpacatinib significantly improved the event-free survival. Safety was consistent, so nothing really out of the ordinary in terms of looking at the data. But I think let's start with Dr. Rashmi. Given that we already have data for EGFR and ALK in this situation in the adjuvant setting, and now with RET, do you think now that lung cancer is now early lung cancer is becoming a more molecular disease, and molecular testing in early lung cancer has now become mandatory, both DNA and RNA based, because both RET and ALK are RNA based testing? So do we now need to start doing comprehensive DNA RNA based NGS in early lung cancer rather than just try to get away with the PCR for EGFR and ALK? Dr. Rashmi, your viewpoint. Dr. Satya, are you there?
Yes, sir.
Yeah. So what is
Hello.
your view on the molecular testing in early lung cancer?
Yeah, so I think as of now we were only testing for the EGFR and ALK, but I think with the publication of this data, we should consider the expanded panels and should be testing for all these relevant genes, and should be treating the patient based on the molecular profile that we are getting.
No, I agree that now as the point of diagnosis, we really need to start doing larger NGS panels with DNA and RNA based to get as much information out as possible. Dr. Jovita, what is your viewpoint on the neoadjuvant therapy in this group of patients, particularly if you look at the RET positive, these patients were included. The only exclusion criteria was EGFR and ALK. When you look at the chemoimmunos neoadjuvant studies, both for Nivo and Pembro, would you be happy giving neoadjuvant to this group of patients, or would you say no, we're just going to go for surgery and adjuvant therapy?
I mean, that call would be, I think so, taken by the surgeon. If the surgeons are comfortable to take up the patient upfront for surgery, then there's no point of neoadjuvant. But if they say that the patient will be definitely benefiting with the neoadjuvant, then obviously we're going to go ahead with neoadjuvant therapy. And in our setup in Cancer Institute, we have started doing, even in early lung cancers, we started having molecular testing done. And going forward, I think it's a very good change in practice for everyone.
I agree that molecular testing now needs to be done at the point of diagnosis for all patients in most of the cancers, let alone lung, but clearly more important in lung cancer. I have to say that the neoadjuvant therapy that the trial data showed was for operable lung cancer, not for borderline inoperable. And they showed good event-free survival, good pathological response rates. But I think all things considered, looking at the Libretto study, I would probably avoid neoadjuvant therapy in this group of patients and go straight for surgery followed by adjuvant chemo plus minus silpacatinib. I would not waste the time looking at neoadjuvant therapy in this group of patients. Dr. Rashmi, your viewpoint on the neoadjuvant therapy part?
So neoadjuvant therapy in early lung cancer.
In RET positive. In RET positive.
Yeah, in RET positive also, I'm not confident enough to use anything right now.
I agree. I agree. I mean, if you look at the study design itself, I think they included patients who received definitive therapy. It could be either surgery or radiation. And I think this was a bit quirky. I thought that most patients would be only surgical rather than surgery or radiation. But a small group of patients also received definitive therapy as radiation therapy, followed by adjuvant chemotherapy. And adjuvant chemotherapy was optional in this group of patients. And I think this is something we need to discuss. The patients were randomized into silpacatinib versus placebo, and the treatment duration of 3 years. And we'll come to the question of 3 years as to whether we think that is an appropriate duration or not. So coming to this patient of 3A, Dr. Ravi Jaiswal has joined us.
No, sir. He has
Uh,
not.
Dr. Ankit, what do you think of definitive radiotherapy for up to stage 3A? Is that something that you would do in your practice, or what group of patients would fall under this treatment paradigm?
I think so. Surgery for stage 3 is still in our institute. We are not routinely going for surgeries,
We're
even
talking
in.
about 3A. We're talking about 3A, not
No,
advanced.
it's somehow still our surgeons are routinely guiding the patients for radical CTRT, all stage 3 patients. That is what the institute practice has been since a very long time. Even now, after the introduction of neoadjuvant treatment, we are more looking towards surgical resectabilities. But as of now, all 3 patients, stage 3, if they are not given immuno neoadjuvant, if they are if they don't have any mutations, the driver mutations, then immuno neoadjuvant, uh, chemo with immuno, and then surgery is what we are planning to do. But routinely, radiation is what we are following in all, routine clinical practice for all stage 3 patients. Even in stage 3A, routinely CTRT is what we are going for.
Fair enough. Fair enough. Dr. Satya, what do you think of adjuvant chemotherapy in this group of patients? Would you give it or would you omit it?
Sir, actually, my personal take on this is I am a proponent of giving adjuvant chemotherapy. I feel that this drug should be in addition to the chemotherapy and should not be replacing the chemotherapy. And my basis for this is the extrapolation from the osimertinib trial, in which we have seen that although I understand that the data from Alina and Adura, they say the line is there that you can give irrespective of the chemotherapy, but I think cisplatin-based chemotherapy still has an important role to play in the adjuvant setting, irrespective of the over the plus with in addition with the TKI.
I would second you, Dr. Satya. I would absolutely agree that.
Sir, only thing is sometimes some patients may not have a adequate performance status to undergo that adjuvant chemotherapy, or they may decline based on their choices. So in that we can just use it the trial protocol.
Fair enough, fair enough. I mean, if they're not eligible or they don't want chemotherapy, that's a separate issue. But chemotherapy has been there for a very, very long time, showing 5% absolute survival benefit. And most of these trials have not shown overall survival benefit. Both the Alina as well as the Libretto have not shown overall survival benefit yet. So I think to replace adjuvant chemotherapy in these situations would be tricky if we subsequently found out that overall survival was not there. So something to keep in mind. And let's not forget that the Libretto is one of those trials that allowed crossover to happen from placebo to sulfatinib on progression. So you might actually not see an overall survival, which is quite common in studies that allow for crossover. Dr. Jovita, what do you think about the crossover allowance in this particular study? Would you think that would impact the overall survival?
I think there would be a confounding of data if I am right, sir. I think that's what there'll be a little bit of confusion as to what really is the one that confers benefit.
Yeah, because are we just delaying the relapse is the question, isn't it?
Yes.
And what do you think of the 3-year duration? Do you think that is appropriate? Should it have been shorter, like 2 years, or maybe longer at 5 years?
I think it's a kind of a fair deal because Adara, we had 3 years of osimertinib, something on lines of that, addressing the microscopic disease. Not too long, not too short. I think 3 years is kind of a right period of time.
Fair enough. Dr. Rashmi, what do you think of the primary endpoint being EFS in an adjuvant setting? Because normally in an adjuvant setting, we like to see overall survival benefit.
Yes, sir.
But we have done an EFS. So do you think
So
that's
the results are promising. The event-free survival is very good, but still the data is immature. So we are waiting for OS results here. So event-free survival is a good endpoint, primary endpoint here, but definitely overall survival we should wait.
I mean, in something like this, it is going to take us a long time to get OS benefit, and we may actually not get given the fact that crossover was allowed. But if you look at the event-free survival, the hazard ratio is 0.17. I mean, it's very difficult to ignore this kind of data, isn't it?
Yes, definitely. That is promising, sir.
It is really, really impressive, data. So, I mean, the other thing I want to discuss is the stage 1B. Is the stage 1B. is the stage 1B. Would you give it to stage 1B patients?
So this data is looking very nice. So I'm waiting just for more results. As of now, nobody is using. I just want to see the results, more results here. Then only we can use it here.
Because the
Osimertinib, we have good results.
the primary even the primary analysis was for stage 2 to 3A. But the inclusion criteria was from 1B onwards. So I think even though the 1B, the data is strong,
Yes.
I think if the patient had high risk factors like MVI, visceral pleura involvement,
Yes. If tumor size is more than 4 centimeter or something like that, we should use.
consider it. But otherwise,
Yeah.
maybe be careful. We've already discussed this. I've already discussed whether we give adjuvant chemotherapy. So let's move on to the other two studies. I do hope we have another 5 minutes to get through this.
Sir, would request you to conclude your presentation in 1 minute.
You want me to conclude? So I'm just going to skip this study because it may not be relevant. I'll just talk to the last study, which was the amivantamab lazertinib. Just for my panelists, this was the cohort C discussion in the rarer mutations, and I think the data was good that Dr. Talreja has already presented. So I'm just going to go to the questions. In an atypical EGFR mutation, would you now consider amivantamab lazertinib as first line? Anybody? Or would you still stick with afatinib or osimertinib?
So we don't have a head-on comparison between osimertinib and AMI and LAZ, or afatinib versus AMI and LAZ. So that's something which goes on my mind as I look at it.
So I think it is one of the options to be considered.
This is phase 2 data. We don't have any randomized trial for this.
I don't think so we'll ever get one given the rarity of it, isn't it? Dr. Satya, would you treat all the three atypical mutations as the same? Or, for example, the L861Q is more typical, and we say that for that osimertinib is better, and for the other two afatinib is better. But for the purpose of giving amivantamab lazertinib, would you treat them all the same, or would you treat them slightly differently?
Yeah, I think, sir, if one thing is the availability of lazertinib in India, that's an issue. But if patient is affording and both the combinations are available and a fit young patient, because I'll tell you my experience with amivantamab has not been very good. A lot of side effects are there in terms of skin toxicity and all. But if it's a fit patient, I think I will treat all as one.
And of course, Dr.
Given the 41 months of median OS.
Absolutely. I mean, given the data that showed by Dr. Talreja that co-mutations, compound mutations, this combination did better. So if those existed as well, I would probably consider giving this combination in those group of patients as well. So thank you, my panelists. I'm just going to conclude with this take-home message. Harmony-6, I think bispecifics are now entering first-line treatment in lung cancer. Libretto, the early lung cancer is now becoming a molecular disease, something we need to keep in mind. Opnitrop, we didn't discuss much, but clearly the ADCs are now entering into the first-line domain. And it is quite nice to see with the Chrysalis 2 that the rare mutations now have more choices for treatment rather than just one. So I'd like to thank my panelists and thank Dr. Sharma and Dr. Somani for giving us this opportunity to have this panel. Thank you very much.
Thank you, sir. Thank you for the excellent presentation. Thanks to all the panelists. And as we move forward, I would like to invite Dr. Priya Tiwari, medical oncologist at Gurgaon. And this session is sponsored by Glenmark and she will be speaking on rational to practice. Over to you, ma'am.
Hello, everybody. Good evening, Dr. Naresh. Thanks for the opportunity, sir. I'll just start sharing my screen. So actually, my task has become very easy. I saw an excellent panel discussion right now. And there's so much that we have now learned about the cancers, about the immunotherapy, about the sequencing, that I feel that our patients are in safe hands all over the country. So yes, a very important drug again, tislelizumab, and a wonderful molecule. I think all of us have started using one of the.
Ma'am, please make it full screen. Okay.
So we have started using one of these newer drugs, tislelizumab, toripalimab, serplulimab. So I'll just discuss about tislelizumab and its data. It's again a humanized IgG4 monoclonal antibody and which very binding specificity for the PD-1. So that means it blocks both PD-L1 and L2 dependent pathways, unlike atezolizumab or durvalumab. Now there's something else also very unique to this molecule. It has a unique binding epitopes, binding kinetics, and distinctive binding orientation to PD-1. Many of you must be knowing the dose is 200 milligram every 3 weeks, and in lung cancer it's until disease progression. And though there are newer studies which are also trying it and limiting the duration till 2 years. And the data is emerging both in the solid tumors as well as hematological cancers across more than 20 potential registration enabling clinical trials in 35 countries. So though this was initially a China limited trials, now all over the world the trials are coming, and also real world evidence is accumulating. So you have evidence for the nasopharyngeal carcinomas both in first line squamous, non-squamous, non-small cell lung cancers, second line non-small cell lung cancers. You also have data in the extensive stage non-small cell lung cancer. Also PD-L1 positive gastric or GE junction tumors, esophageal cancers, HCC in both first line, second line and beyond. You also have data in the urinary bladder cancers, second line data in MSI positive tumors. And you also have data in the classical Hodgkin's lymphoma, and this is one such drug where you also have data for the NK T cell lymphomas or the mature T cell lymphomas. So quite a number of indications in the data set to actually find the tislelizumab and usage and comparison and efficacy. So we'll discuss few of these trials, number of trials, mostly they go by the name of rationale series of trial 303 in the non-small cell lung cancer, 304 also in the lung cancer, 307 will study in the detail. You have 312 for the tislelizumab plus chemotherapy versus chemotherapy alone as first line treatment in extensive stage non-small cell lung cancer. Sorry, extensive stage small cell lung cancer. So, and we'll just briefly touch upon this in the end too. Excellent study. You have rationale 311 phase 3 study of tislelizumab plus chemoradiation therapy versus chemoradiation therapy for the localized esophageal squamous cell carcinoma. So, lot of data and a very important studies overall. And so this was the one that I was referring to, the NPC phase 3 study of tislelizumab plus chemotherapy versus chemotherapy alone as first line treatment in recurrent or metastatic NPC. And the MSI high positive tumors, MSI high tumors, classical Hodgkin lymphomas, and so on. Tri-Hall study and BGB A317203 study. So tislelizumab, what makes it actually unique? So we actually don't go about knowing the pharmacokinetics or the structure of each immunotherapy molecule. Sometimes we say and we feel that maybe all the immunotherapy molecules are actually same, but we should definitely try to see if there is a difference available, because that actually gives you confidence in using a molecule. And sometimes you have this concept of low dose. So you know that if a molecule works in a lower dose too, what should be that minimum possible lower dose for that particular molecule? Is it same for pembrolizumab versus nivolumab? So I think understanding the structural, the structure of the molecule as well as the pharmacokinetics are very, very, very important. So tislelizumab has a distinctive binding orientation to PD-1, and it has been identified that yes, these are the very unique binding epitope. The binding orientation to PD-1 differs to that of pembrolizumab and nivolumab, as well as the binding kinetics are different. The binding surface of tislelizumab on the PD-1 overlaps largely with that of PD-L1, leading to the complete blocking of the PD-1-PD-L1 interaction, more than 99%, and also for the PD-L2. So pembro and nivolumab with different binding orientation showed partial PD-L1 blockade up to around 80-81%. So this is very, very important aspect, that yes, how much receptor occupancy is there and how much the inhibition, the complete blockade is being achieved. Also what we understand that when we talk about all this PD-1, PD-L1 axis, This has a very important part too, and another part, that is PD-1 monoclonal antibody with Fc gamma receptor binding. So what we know that the T cells are activated by binding of the TCR to the MSC antigen complex on antigen presenting cells or the tumor cells. Upon T cell activation, PD-1 expression is induced, and it can upregulate PD-L1 expression to turn off T cells to escape immune surveillance, and that is how we know that the cancers progress. Blocking the PD-1 PD-L1 signaling pathway by an anti-PD-1 antibody allows T cell to maintain their effective functions, and that includes the structure of the tumor cells and cytokine production to activate and recruit other immune cells and so on, and thus limiting the cancer propagation. Now, anti-PD-1 antibodies which bind to Fc gamma receptors mediate cross-linking between PD-1 T cells and Fc gamma receptor positive macrophages, which induces macrophages to phagocytize these PD-1 positive T cells and possibly diminish anti-tumor response. So somehow if we are able to eliminate these kind of receptors, we'll be able to have these kind of molecules for a longer time in the body, and yes, better cancer control. So this is what happens here. Anti-PD-1 antibody engineered to lack Fc gamma receptor binding capability, and anti-PD-1 antibody with Fc gamma receptor binding capabilities are the two important ones, and there is a difference definitely between these two. So an anti-PD-1 antibody, as I said, without Fc gamma receptor binding may allow T cells to remain activated and maintain effector function, and that is what we see here. So this is the difference between the antibody which has an Fc gamma receptor binding and one that does not have an Fc gamma receptor binding. So that is what the importance of tislelizumab is. So you remove this part and you get a molecule to stay in the body for a longer time and achieve better anti-cancer control. So yes, in the preclinical models, it was also seen that the tislelizumab demonstrated high target affinity and slow dissociation, that you can see by these graphs. So you see here plateauing compared to pembrolizumab as well as nivolumab. So this might be clinically relevant too, because it's seen that it is around 50 to 100 times slower, and it has the other important thing is, again you can see by these curves, that is a lower half maximal inhibitory concentration value, thus having a stronger anti-tumor activity. And this is a very important role in choosing the dose also, isn't it? So its half-life is approximately 30 to 80-fold longer than that of pembrolizumab and nivolumab respectively. So sometimes, when we talk about a drug being administered in real world setting, we also not just talk about the doses, we also talk about the duration. And so we know that sometimes these are the drugs where a longer gap sometimes can also be allowed, especially if your patients are coming from a far off places. And the IC50 values of pembrolizumab and nivolumab are actually 1.3x to 3.5x higher compared to tislelizumab. So overall, the tislelizumab gives you a lot of freedom in the real world setting when you are sitting in your OPD to actually help in multiple tumors to choose the best possible combination which suits not only to the data available but also to the patient needs. Now we'll just touch some cancers. Non-small cell lung cancer. This is a very important study, tislelizumab plus chemotherapy versus chemotherapy alone for advanced squamous non-small cell lung cancer, first line data, rationale 307. Now this actually study had 3 arms, tislelizumab plus pacli 175 mg per meter square and nab-paclitaxel, the weekly dosing. So this was pacli versus nab-pacli versus just chemotherapy. The only chemotherapy arm had paclitaxel, followed by maintenance with tislelizumab in these two particular arms wherever you have tislelizumab. Now the important thing was that this trial actually allowed crossover too, and there were a number of stratification endpoints. The primary stratification factors, the primary endpoint was PFS by IRC, and I need not show that to tell you a lot of things here, but you can see by the separation of the curves that yes, the addition of tislelizumab does make a difference to your patient, whatever be the chemotherapy backbone. So whether you have a whether you have a nab-paclitaxel or you have a paclitaxel, this does make a difference and adds to just chemotherapy for your patient. So PFS was significantly improved with tislelizumab plus chemotherapy compared with chemotherapy alone at a median follow-up of 16.7 months, 55%. In this particular group, reduction in risk of progression at 57%. And you see that the difference is there wherever you have a sizable population. See, sometimes when you have a very small number of patients, or whenever you have so whenever you have a small number of patients, you see a wider confidence interval, and sometimes you see that the values might be touching 1. But here we see that wherever you have a sizable patients population, it is actually favoring the combination. And also when you see a PD-L1 expression, we see that even any PD-L1 more than 1% or more than 50%, it is actually quite favoring the patients. So whether it is PC arm with tislelizumab versus nab-paclitaxel. So the number of females is quite small, so I think that is why you see a wider confidence interval here. So PFS was significantly improved irrespective of PD-L1 expression or the disease stage. So even patient with the liver metastasis, patient irrespective of smoking status, all this is quite helpful. And if you talk about the response rate, again, tislelizumab addition helps in improving the response rate, it helps in improving your CR rates, and overall disease control rate, duration of response rates, 8.2, 8.6, 4.2. So more than doubling of the response, duration of response that we see. Now, overall response rates plus overall survival, if we talk about 26.1, 23.3, and 14. So again, an improvement in C. So the question was whether if you have having a crossover, so a supportive analysis was conducted to adjust for the potential impact of the in-study crossover using a two-stage model. There was slight reduction in HR, but we do see that in the intention to treat analysis, you do see a reduction, but yes, by the two-stage model, you definitely, which takes care of the effect of crossover, we see yes, the difference is convincingly favoring the addition of the tislelizumab. No,
Ma'am, sorry to interrupt. Ma'am, please conclude the session.
Okay. So the other important factor is tislelizumab treatment beyond progression in advanced squamous carcinoma after first line, and we do see that yes, a benefit is seen beyond progression too. So in real world setting, sometimes we are wondering if the disease is progressing, whether you should want to continue or not. But we see here that yes, some benefit is observed even by continuing it beyond progression too. So this is actually open to a larger trial. This is just a retrospective analysis, but yes, a difference is seen. So, while there is a limitation of the retrospective analysis, tislelizumab treatment beyond progression might bring survival benefits for the squamous non-small cell cancer patients after disease progression on first-line chemoimmunotherapy without increasing safety risk. Patient with low or intermediate risk tends to have longer overall survival, suggesting a potentially beneficial population that needs further investigation. And yes, it needs to be confirmed in larger prospective studies. So thank you. That will be all.
Thank you, ma'am. Thank you for your excellent presentation. Do we have any questions?
So presently with these newer drugs, which we often call the Chinese drugs, you stop at the 2 years in a responding stable patient, or you go beyond 2 years?
So, sir, because this has been a recent addition, we have yet not had a patient going beyond 2 years. So, suppose in my clinical practice, what I do, so this is not different for the Chinese versus non-Chinese. What I usually do is, if the scans are showing complete response, I would stop. But suppose if it is not, if it is anything less than CR, I would continue. So like if there's some FDG avidity going on, there's just an ongoing partial response, I would not stop. I don't do it for the rest of the drugs, I would not do it for the Chinese IOs. I would only stop if there's a CR. Or maybe if there's just some slight uptake, I'll do a biopsy. If it is negative, then only I'll stop. But mostly I need to have no evidence of disease, then only I'll stop it. But yes, I do stop it at 2 years for many patients.
Thank you.
Thank you.
So
Thank you,
what do you do in
ma'am.
your practice, Dr. Naresh? What do you do in your practice?
So, I mean, the available PD-1 inhibitor which we use in the first line, like Atijo or Pembro in the first line, because maximum response comes at the end of the 12 to 15 months. So my intent remains to stop at the 2 years, looking at the various aspects, not only the toxicity, the financial burden also, and the present concept say that it's the 2 years sufficient. And probably that's we are extrapolating for other malignancies also, like RCC, wherever we are giving these sort of drugs. But yes, if you talk about, like, let's say the Ruby trial, which says in the endometrium that you go to the 3 years. The trial itself says that it's a 3 years. So you can't stop at the 2 years, even if the best possible response, CR or near CR, whatever it is.
Makes sense.
Thank you, ma'am. Thank you so much. And we move forward for the next session, which is sponsored by Roche. And for this, I would like to invite Dr. Ashmita Jain, Senior Consultant Medical Oncologist, Action Cancer Hospital, Delhi, for her talk. Over to you, ma'am. Dr. Ashmita.
Yeah, am I audible?
Yes, ma'am.
Okay, okay. So, very good evening to all. And thank you, Dr. JB sir and Dr. Naresh, for giving me this opportunity to present this session. So, can you please share the slides for me?
Sure. Pooja, kindly we share the slide.
Yeah. So, I will be talking about Tecentriq subcutaneous, a pioneering innovation in NSCLC with subcutaneous immunotherapy. Next, please. So, this is my disclaimer. This is a sponsored sessions by Roche, and Roche does not promote or support the use of medication manufactured by it off-label indications. So this is the disclaimer. Next slide, please. So first, coming to the Tecentriq subQ, AMSkin 01 and AMSkin 02 studies and the approval timelines. So AMSkin 001 was conducted in two parts. The first part was a phase 1B, which was a dose-finding study, and the part 2 was a phase 3 randomized non-inferior study. So phase 3 has the co-primary endpoints as a cycle 1 observed CTRA and a model predicted AUC extending over a period of 0 to 21 days. IMSkin 002 was a primary endpoint proportion of patients who preferred subcutaneous versus IV at the 6th cycle. So this was the timeline. Initially, it was presented in ESMO December 2022 and it was UK launched in August 2023. It got a MI approval in January 2024 and then FDA approval in September 2024 in the same year. And also we got an Indian DCGI approval in September 2025. Next slide, please. So this is the first PD-L1 subcutaneous cancer immunotherapy, which is now approved in India. Next. So what is the formulation? Formulation with recombinant human hyaluronidase, it allows a subcutaneous administration of larger volumes. So how does it work? The recombinant human hyaluronidase, it temporarily and locally degrades the hyaluron at the site of injection with no changes in the structure, providing macromolecules, collagen, or the elastin. So the degradation of the hyaluron results in a temporary increase in the local subcutaneous dispersion area, enabling larger volumes of fluids to be administered. So after this subcutaneous administration, the architecture of the skin is reformed within 1 to 2 days due to rapid clearance of the recombinant human hyaluronidase and faster hyaluron turnover. Next slide, please. So coming to the study design of IMSkin 01. So it was a phase 1B and phase 3 global multicentric randomized studies. The drug exposure, efficacy, and safety profile of Tecentriq subQ has been assessed versus the Tecentriq IV. So it was an open label multicentric study. It was conducted in two parts. The first part, the phase 1B, was a dose finding study, and the part 2 was a phase 3 randomized non-inferiority study. The phase 3 study investigated the pharmacokinetics, efficacy, immunogenicity, and safety of Tecentriq subQ versus Tecentriq IV as second-line treatment in patients with locally advanced or metastatic NSCLC. So coming to the inclusion criteria, histologically or cytologically documented stage 3B to 4 NSCLC. All these patients were immunotherapy naive and they failed to the first-line platinum-based chemotherapy. Measurable disease defined by the RECIST version 1.1 criteria and ECOG was PS0 and 1. So with the randomizing two arms, Tecentriq subQ and Tecentriq IV. SubQ was given in a dose of 1875 mg every 3 weekly, and Tecentriq IV was given at a dose of 1200 mg every 3 weekly. So it was continued in the progressive disease as per the RECIST, unacceptable toxicity or loss of the clinical benefit. So coming to the phase 3 co-primary endpoints. There were two primary endpoints. First was a cycle 1 observed CTRA and model predicted AUC 0 to 21 days. The phase 3 has secondary endpoints, which consisted of the safety, efficacy, overall response rate, duration of response, and investigator assessed PFS. Also the immunogenicity. So the endpoints differed because it was they were not testing a new drug. They were basically testing the formulation, a different formulation of a drug which has already been approved in all these indications. Next slide, please. So the pharmacokinetic parameters are important for understanding the bioequivalence between the IV and the sub-Q formulations. So the PK endpoints are a key focus of the Tecentriq sub-Q. As we can see in this graph, over the period of time, the Cmax was achieved earlier in the IV formulation as compared to the sub-Q. But as the time passed, the Ctrough was maintained as a high level in the sub-Q formulation as compared to the IV formulation. Next slide, please. IMSkin 001, the efficacy primary endpoints. It has a positive readout, and Tecentriq sub-Q was considered non-inferior versus the Tecentriq IV. So, coming to the first co-primary endpoint, the GMR was 1.05, which was non-inferior, and the model predicted cycle 1 AUC, it also has a GMR of 0.801, again non-inferior against the IV formulation. Next, please. Exposure of Tecentriq sub-Q was consistent with those observed with Tecentriq IV across the approved indication, as we can see in this. All the other indications apart from NSCLC like SCLC, melanoma, urothelial, and the HCC, it was consistent. The systemic drug exposure following Tecentriq was consistent with that from other approved IV clinical studies and supposed to use of sub-Q for other approved indications also. Next. Tecentriq sub-Q and IV had comparable efficacy profile. IMSkin 001, the secondary endpoints median OS. So as we can see in this Kaplan-Meier curve, the median OS was 10.7 months with IV formulation and 10.1 months with the. So it was again non-inferior systemic exposure, which resulted in similar efficacy for both routes of administration. Next. Tecentriq sub-Q and IV had comparable efficacy profile. The IMSkin 001, the secondary endpoints were median PFS and ORR. So as we can see in this graph, the median PFS with Tecentriq IV was 2.9 months as compared to 2.8 months with the subcutaneous formulation. It was again a non-inferior. And the objective response rate was 11.8 versus 9.7 with the IV formulation with a confidence interval of 95%, which is again a comparable efficacy profile. Next, please. So coming to the safety summary. So again, we can see the safety summary in both the arms were comparable. With the subcutaneous as well as IV formulation, they had similar safety profiles. Especially the grade 3 and 4 reactions, adverse reactions were comparable in both the arms. The number of injection sites was low with Tecentriq sub-Q, and they were grade 1 and grade 2 in severity. As expected, no infusion-related reactions were reported in the subcutaneous arm. No new or unexpected safety signals were identified. So again, shows similar safety profiles, which was a major concern. Next, please. Coming to the administration time, the median administration time was 7.1 minutes with the subcutaneous formulation. Median administration time was Tecentriq sub-Q and IV, and distribution can be seen in the following histograms. So as we can see, the median administration time was 7.1 minutes for the subcutaneous formulation and 40 minutes for the Tecentriq IV. So majority of patients receiving subcutaneous formulation had the average injection time between 4 to 8 minutes. Next, please. So it's pioneering new administration options for the patients. IMSkin 002. So this was patient-reported preference for Tecentriq sub-Q. So what was found, approximately 80% of the patient, they chose a subcutaneous formulation over the IV formulation after having an experience with both the formulations. Next. So coming to the study design of IMSkin 002, it was a phase 2 open label crossover study of Tecentriq sub-Q versus IV in patients with PD-L1 positive NSCLC. So eligible patients were greater than 18 years old, the ECOG 0 to 1, no driver mutations, resected stage 2B, 2 to 3B, NSCLC, who have completed the adjuvant chemotherapy, PD-L1 positive, greater than or equal to 1%, stage 4 NSCLC, which are chemotherapy naive with the high PD-L1 status. So they were stratified based on the disease stage, the type of surgery they underwent, and they were randomized in the ratio 1:1. The crossover period was of 6 cycles. So in either arm, the patient were first given subcutaneous formulation in the dose of 1875 mg every 3 weekly for 3 cycles, followed by Tecentriq IV 1200 mg every 3 weekly. And the crossover was allowed after 3 cycles. And the patient was given a choice based upon the patient preference questionnaire, what further therapy he want to have, whether it will be an IV or a subcu therapy. And then according to the patient's choice, it was continued for the further period for a total of greater than 16 cycles in resected stage 2 to 3B NSCLC or investigator assessed. So the key secondary endpoints was patient reported satisfaction, patient choice of treatment, the safety, including the safety of switching between the formulations. Next. Coming to the patient demographics and the baseline characteristics, they were very well matched in this study, as we can see in these demographics. Next. So what were the trial outcomes? The primary endpoint was the patient preferred administration method. So as we can see, 70.7% of the patient preferred subcutaneous formulation over the IV formulation. And the main reasons for preferring the Tecentriq subcu was lesser time at the clinic, more comfortable, and less emotionally distressed. Over 70% of the patient prefer subcutaneous formulation. And coming to the patient satisfaction with the subcutaneous formulation. So as we can see in this pie chart, nearly 41% of the patients were very satisfied and nearly 45% of the patient was satisfied with the subcu formulation. So over 85% of the patients were satisfied or very satisfied with the Tecentriq subcu. Overall safety profile was consistent with the established Tecentriq safety profile and no new safety concerns were identified. Next, please. So 8 out of 10 patients chose the subcutaneous formulation over the IV to complete their treatment. All patients who preferred Tecentriq subcu chose subcu for the continuation period. 79.4% of the patients, they preferred the subcu formulation for the remaining cycles. Next. So what was the reason why the patients were preferring the subcutaneous formulation? First, it requires less time in the clinic. 64% less time was needed because the administration time was an average of 7 minutes as compared to 40 minutes with the IV formulation. It feels more comfortable and it is less emotionally distressing as reported by 30% of the patients. Next, please. What were the healthcare prediction reported outcomes? The HCP perception of the most convenient method of atezolizumab administration with the subcutaneous formulation, 75% of the HCPs preferred a subcutaneous formulation. And the HCP perception of which administration methods is used. As we all know, the IV formulation needs time for the mixing as well as administration, which was cut short in the subcu formulation. Next. Switching between the Tecentriq subcu and Tecentriq IV, it was very well tolerated. As in the study design, the patients were given 3 cycles either of the IV or the subcu first, and then they were allowed to switch over to the subcu or the IV arm or vice versa. So overall safety profile, the crossover and the continuation was consistent with the established atezolizumab safety profile. No new safety concerns were identified. Switching between the atezolizumab subcu and IV, regardless of sequence, was well tolerated. The likelihood of a patient experiencing an injection site reaction or infusion-related reaction event did not increase when switching between atezolizumab subcu and IV or vice versa. So as we can see, All the adverse events were well comparable. No safety concern was there, whether the sub-Q was given first or the IV was given first, and the switchover was smooth with no safety concerns. Next, please.
Dr. Asmita, great slides, but you have another couple of minutes to conclude, please.
Okay, sir.
Excellent slide,
Yeah,
please.
sure. Next, please. So you can now advance your patient care with Cetirizine sub-Q. It is approved as a monotherapy for the treatment of metastatic NSCLC with PDL1 greater than 50%. Metastatic NSCLC patients progress from prior chemotherapy as per the OAK trial in 2017. Adjuvant NSCLC patients with PDL1 greater than 1%. Next. Tecentriq sub-Q in NSCLC, as we can see, three major studies, IMpower 110, the OAK, and IMpower 010. In all the three settings, it delivers whether it is a first-line metastatic NSCLC, a previously studied NSCLC in the second line, and adjuvant NSCLC after the adjuvant chemotherapy. Tecentriq delivers survival benefits across the NSCLC journey, from curative intent adjuvant to durable control in the advanced disease. Next. Next. In IMpower 110, So in IMpower 110, the first-line Tecentriq monotherapy demonstrated a 40% reduction in the risk of death versus platinum-based immunotherapy. So it's a major thing. At the end of 1 year, 2 out of 3 patients were still alive. And the final OS analysis showed that 22 months median OS as compared to 13.1 months. Next, please. Also in the OAK study, there was a 22% risk reduction of death as observed with Tecentriq versus docetaxel in the intention to treat patients. Increase overall survival rates across all the PDL1 groups. Next. In IMpower 010 again, as we can see, the median OS was not reached in the patients who were given adjuvant atezolizumab. Next, please. So coming to the flexibility and the economy. Next. Next, please. Yeah. So it does not require any dilution. It is a ready-to-use solution and enable further optimization. So no complexity such as an IV pack preparation or loading doses are required. Next. So what is the flexibility? It reduces the chair occupancy time. So it's given a fixed dose. No preparation is required. It is a ready-to-use injection and approximately 7 minutes are used as compared to the IV formulation, which needs a 60 minutes of initial infusion in the first cycle, and if tolerated, 30 minutes for the subsequent. Next. So what is the resource utilization? The positive impact of the sub-Q formulation on the resource center. So utilizing Tecentriq sub-Q in place of IV CIT would be economically favorable, as we can see in this data. If we treat 100 patients over a period of 6 months and giving by the 3 weekly schedules, we will be requiring 900 sessions. And with the sub-Q also 900 sessions, but the time taken to administer will be 7 minutes as compared to the 30 minutes. So the overall total chair time released over a 6 months period is nearly 2 weeks, which is significant. Next. So Tecentriq sub-Q provides a more streamlined approach of administration during both induction and maintenance therapy, offering significant operational benefits in clinic like ours. So the healthcare time is reduced by the 66% and the costs are reduced by greater than 33%. Next. So I will summarize. Next, please. So Tecentriq sub-Q is the first PDL1 subcutaneous CIT. It is now approved in India in January 2025. So comparable efficacy and safety as compared to the IV formulation. Utilizing Tecentriq sub-Q in the place of IV CIT can save 2 weeks in 6 months, so or 1 month in a year. So Tecentriq sub-Q would require 2/3 less healthcare practitioner time and 1/3 lower cost as compared to the Tecentriq IV. Next, please. So I can conclude same efficacy, same safety, less time, and more convenience. That is the promise of subcutaneous Tecentriq. Thank you so much for the patient care.
Thank you, Dr. Asmita, for such a wonderful presentation. I hope there might be some questions which can be asked into the chat box. Now, with the paucity of the time, I would like to invite the next speaker, which is again a very, very interesting discussion. This is Seripulumab, the next generation IO transforming lung cancer. And for this talk, let me have Dr. Mukesh Patikar, sir, Associate Director, Medical Oncologist at the prestigious BLK Max Hospital at Delhi. So with this, Dr. Patikar, sir, I'm sure you're there.
Yeah, thank you, sir.
And I request you to please share your slides.
Yeah, thanks for invite, sir. So after a wonderful session by Dr. Priya, followed by Dr. Asmita. So I'll just take you through another blockbuster molecules which is recently come into the picture.
So
So
please make it full screen.
Yeah, just a second. So yeah. So my topic is heteronifly, that is serplulimab, the next generation IO transforming the lung cancer treatment paradigm. So basically, as per Global 2022 data, the lung cancer stands fourth most commonly cancer in India, and its incidence is continuously is rising trend. Coming to the molecule serplulimab, it is a another IO which is cost effective and is as efficacious as other molecules, which is already approved in Europe as well as in India. So India, it has a approval for a small cell lung cancer extensive stage. In Europe, it is small cell, non-small cell. So it has multiple approval. In China, obviously the origin of the molecule from China, so they have multiple approvals. The main important point I want to stress out is a STRIDE study, which was the randomized trial, randomized control trial, which compares serplulimab versus atezolizumab in treatment naive extensive small cell lung cancer United States, and enrollment have been completed. So we are expecting results over the period of time. So basically, to review this trial, so the patient with extensive stage small cell, they were randomized into the two arms. One was serplulimab 300 mg day one along with the standard chemotherapy, which we usually use for 4 cycles, followed by serplulimab maintenance. In Atezo, it was given 1200 mg along with the carbo etoposide for 4 cycle and Atezo maintenance. The post end of treatment or serplulimab second line chemotherapy until second period loss of clinical benefit was there as a landmark, and it is same for atezolizumab. So what's different this molecule as compared to Priya just told us about the tislelizumab, and we know that we have Keytruda, we have BMS nivolumab drugs. So what is this molecule? What are the peculiarity? So it is not the an identical PD-1 inhibitor which we supposed to have as we have earlier molecules. It is a novel anti-PD-1. It is a IgG subclass 4 molecule. It contains constant heavy chain, variable heavy chain, and light chain as it has. And binding affinity is 10 times higher than nivolumab and 3 times higher than pembrolizumab. These are the blockbuster molecule we have in our armamentarium in last 10 years. So being 10 times more affinity, so they are tend to have better interaction with the PD and PDL1 in pathway and having the anti-cancer activity. Coming to this superiority of this PD-1 internalization compared to Pembro and Nivo, which is very much important. So when a new molecule comes, we need to understand why it is different. So whenever there is this molecule, the PDM forms a cis complex with the CD co-stimulator receptor, and this co-colonization would bring CD-associated intracellular kinases essential for T-cell co-stimulation. So this serplulimab blocks this clustering of CD28 and with PD-1 during the T-cell activation better than pembrolizumab. These are the studies was done in the labs, and we can see that the difference is here. Coming to the Astrom 005, so this was a phase 3 study. The patients were randomized into two arms. One was serplulimab 4.5 mg per kg day 1 on carboplatin etoposide as standard doses. In 2:1 fashion, the placebo and carbo was given, and in maintenance, the surplus was continued till the disease progression or intolerable toxicity. The primary endpoint of this trial was overall survival. The secondary endpoints were PFS, PFS2, overall response rate, duration of the response. This trial was conducted across the 6 countries, around 114 sites, including China, Georgia, Poland, Russia, Turkey, and Ukraine. Another thing is that 25% patients do have liver metastases, 13 patients had brain metastases, 81% patient had PS1, and 80 more than 80% PDL negative status were also there. Coming to the primary endpoint, so this is the data. 4-year OS rate was 21.9%. The delta of OS was 4.7. We can see here this Kaplan-Meier curve shows as soon as within 2-3 terms the curves are separated apart and they keep separated at 1 year, 2 year. There is a stark difference between the data. 2 years OS rate was 32% versus 16. There was a doubling of the OS rate at 2 years and 3 years, and for almost at 4 year you can see that it is a tripling of the OS rate. So those who survive, they are continuously maintaining their remission over the period of time. The hazard ratio was 0.60, which means that the median OS of 15.8 and 11.1 for chemotherapy with delta 4.7 confirms there were 40% less events with this serplulimab addition to this chemotherapy. Coming to the subgroup analysis, we can see that both Asian and non-Asian population, those who have a brain mets or those don't have brain mets, they also showing trends toward having the benefit of serplulimab addition to the chemotherapy. Similarly with the liver, whether it is present or not, we know that liver mets are a negative predictor for the benefit. And generally, we don't do PDL1 for small cells. So irrespective of PDL1 status, the benefit was sustained and irrespective of age. So this forward plot analysis shows that OS benefits are consistent across the subgroup. Uh, Coming to the secondary endpoint, the PFS. So it has the longer median PFS, 5.8 months versus 4.3 months with hazard ratio of 0.47. So the confirmed overall response rate was serplulimab chemotherapy 68.9% and 58.7% with this molecule, and this shows the same thing at 12-month. PFS rate was 27.7 versus 6.9, and at 24-month 12.4%, 2.9%. So these are the like we don't have to do cross comparison, but this slide is there. So I'll just go through this slide, and we can also make out the difference between different trials like Astrum 05, IM Power 133, and Caspian. So we know that serplulimab is anti-PD1, atezo is anti-PD-L1, and durva is PD-L1. So technically they're slightly different, but median voice was 15.8 versus 11.1, which is highest as compared to other two molecules. But the in placebo also the benefit was 11.1 months. So it may be related to the different patients and different trial design. Hazard ratio was 0.61, the lowest as compared to 2. OS rate was also better at 2 year, 3 year. And we can see that there is no update at 4 years OS rate, but at 2 year, if you compare, 33% was the highest for serplulimab as compared to atezo and durva, 22% respectively. The FAF is 5.8, which is I can say consistent, numerically better with the this one. Overall response rate was 68%, 67%, 60. So they are comparable. Duration of response is also highest, numerically 6.8 months versus 4.2 and 5.1. So this is the magnitude of clinical benefit scale, which I already seen with other drugs like ribociclib. This is standard thing to report the benefit of the certain molecules, and we can see that serplulimab ranks fifth. That is the means they have substantial benefit of this molecule in that particular situation. Coming to the updated safety analysis, grade 3 and more toxicity was 83.3 and 81.6, which was comparable. Serious adverse events were 37 and 36, both are comparable. Immune-related adverse events were 37.8 month versus 19.4. So there is a delta of 20%, but it's expected when you give IO drug. And treatment discontinuation was 5.9 with this group versus 5.1. And there were 5 deaths in the serplulimab chemotherapy arm versus placebo chemotherapy. The landmark trial for IO plus chemo for non-small cell lung cancer, they also enumerated here. So we have these trials like Keynote 407, Checkmate 9LA, and IMPAR 131. So I'll just skip this slide because it is just there is no comparison with this molecule as of now. Coming to the serplulimab Astrum 004, it is a serplulimab plus chemotherapy as a first-line treatment for advanced squamous non-small cell lung cancer. First, we'll go through this trial, then we'll see this first slide I just skipped right now. So in this also, the patient with squamous, they have given napacli carbo along with serplulimab, and serplulimab maintenance, and comparator was napacli carbo weekly day 1, day 8, day 15 schedule. The primary endpoint PFS. Here we can see that the median PFS was 8.3 month versus 5.7. Stratified hazard ratio 0.55. There was 45% reduction in the risk of progression as compared to other molecule placebo, and 12 month and 24 month PFS rate favors the serplulimab.
Dr. Mukesh, sir, great discussion. If you could just conclude, because there's 1 or 2 questions for you on the chat box.
Yeah, okay. So the even oral benefit is also maintained. The tumor response rate was also 60 versus 40%, and there are no safety new signals. The toxicity is comparable to other drugs. So to conclude, with 30.1 month follow up, so there was PFS OS benefit. And this is environmental in non-squamous non-small cell, that is Astrum 002 study. I'll just go through the conclusion. Yes, here also the median OS was favoring the serplulimab-based combination. Subgroup analysis showed benefit with critical brain mets and TPS 50 also. If they are negative, still the benefit was maintained. PFS benefit was also there, 46% reduction in the risk of progression. And to conclude, addition of the serplulimab to the chemotherapy significantly improved the OS and continue to confer improvement in other efficacy endpoints. Addition of the bevacizumab serplulimab plus chemotherapy did not demonstrate further benefit, and the combination of serplulimab chemotherapy stands standard of care in both non-metastatic non-squamous cell lung cancer, whether they are squamous or non-squamous. Addition of the BEV did not add anything to the much clinical benefit. With this, I'd like to conclude. Thanks for opportunity.
Thank you, Dr. Mukesh. But you have one question on the chat. If you can just answer that, maybe that's we could. I think there's one question. Can you see this?
Let me see, sir. Yeah. Sir, basically, like this question by Dr. Rajat Bajat, definitely, as I earlier told that we cannot do cross-site comparison. So in my clinics, I always inform patients that we have that innovator molecules, and we have this molecule of the Chinese origin. So when the patient is affordable, I am more comfortable with Atezo and Durvam also. Personally, I have not used that much serplulimab to come to the conclusion to I will deviate my practice straight away from these two molecules. So, so I will wait for my experience to build on. Then I can say with conviction whether I will use serplulimab in all patients, irrespective of financial status.
Great. So thank you so much, sir, for this. And now I think we're moving to. So thank you so much, Dr. Mukesh, for such a wonderful discussion. We are now moving forward, and now it's a great pleasure to welcome and invite Dr. Bharat Vaswani, sir. So Dr. Bharat Vaswani, sir, will take us to what has been presented in this year ASCO 2026, the new outlook with respect to breast cancer. So may I request Dr. Bharat, sir, if you can
Good evening, everyone. Am I audible, sir?
You are absolutely audible. We can see
Yeah,
you
so
well.
let me share my side first.
Yeah, Pooja, allow Dr. Bharat sir to share the slide. Sir, over to you, please.
1 minute. So are my slides visible?
Not yet, but yes, now we can see you well. Over to you,
Yeah.
slide. Yeah.
So first, let me thank Somani sir, Sharma sir for the kind invitation. I have been given a task to present what was new in this ESCO 2026 in terms of breast cancer. And I'll be presenting 3-4 study in a very fast way, but giving away the most important point that was made out. So if I tell you the most important study which was presented in this ESCO in breast was the Optima phase 3 study. I think so. It was not in that what we say the plenary session, but this was the most important late breaking aspect in terms of breast cancer. Now, the biggest subset of patient in a metastatic CA breast is hormone receptor positive, basically, or I can say even in one was is a ER/PR positive and HER2/neu negative subset. Now, when I talk about adjuvant setting, do we really require to give chemotherapy in our ER/PR positive, HER2/neu negative? At present, most of the decision that we make in India is based on clinical judgment. Of course, we have two I can say two types of tests that we do: Oncotype DX, and we are doing in India Can Assist test. So Oncotype DX, there was Taylor and RX Ponder study. Now, this study tested Prosigna 50 gene signature. If you remember, these are 50 genes that gives a score from 0 to 100, 0 to 40 low, 40 to 60 intermediate, more than 60 high. But for this study, they took 60, less than 60 or more than 60. So the study was, it demonstrated basically that there are two things we remember. At what time we use Oncotype DX, it is only till N1 disease, so 3 nodes positive. But this study used this up to 9 nodes positive. So another N2 disease, that is 3A, they took. Now, what was different from this study was, first time a study included N2, more than 3 nodes, unlike RX Ponder where only N1 were included. These were 18% of patients. I'll tell you the data. And more importantly, the debate goes on that what works in premenopausal, why chemo should be given is, we all premenopausal women had received ovarian suppression. So this was probably, I think, the most important thing that, so if you are premenopausal, every lady should take it ovarian suppression plus endocrine therapy. So probably that maybe negated that whether we should really use a chemo or not. So the Optima hypothesis was that number of involved node does not affect chemotherapy response if the score, genomic score, is low. So 1 to 4, 4 to 9, if your genomic score is low, no need to give chemotherapy. So try to concentrate on it. 4,000 patients data, they were randomized to chemo plus endocrine. See the upper part of the data. So depending upon clinical risk, all were given chemo followed by endocrine, and they were subsequently tested for Prosigna. In the other arm, it was 2,094 patients. They were distributed. First did a Prosigna, a score of more than 60, which were around 600, and less than 60, which was around 1,400. So women more than 40 with excised breast cancer, no neoadjuvant was allowed, 0 to 9 lymph node, and neoadjuvant was not allowed. So randomized to give chemo plus endocrine based on clinical risk. The other arm, they did a Prosigna and then divided it whether you require a chemo followed by endocrine or endocrine. So this was the important subset. Out of 2,059 patients which were given chemo followed by endocrine, 1,350 had a risk of recurrence less than 60. So probably they would not have required a chemo, but they were given chemo. And on the other arm, when they did a risk of recurrence score, 1421 has risk of recurrence scores less than 60. So probably these are the subset whether you should have to compare directly. So the endpoint was invasive breast cancer-free survival, which included recurrence plus non-breast cancer malignancy. So the overall inferiority margin was 3%. And when you have a risk of recurrence score less than 60, it was 3.5. Please remember 3 and 3.5. Now, around 38% were premenopausal, which was given ovarian functional suppression, and 18% had 4 to 9 nodes positive. Actually, I will be more interested in knowing this. What was the data? We know in 1 to 3, we have a good data based on responder study. So try to concentrate. The primary endpoint overall between control arm and test-directed arm, the recurrence was 7.2 versus 7.3. So that inferiority margin of 3%, that was satisfied. But for those patients where the risk of recurrence score was less than 16, control arm, it was 1358. These all had received chemo followed by endocrine, and the other arm, which was 1421 patients, which had received only endocrine with ovarian function suppression. Again, you see the IBCFS event were only 5 versus 5.3. So probably approach that gives you the same advantage, and you can very well avoid chemotherapy when your recurrence score is less than 60. Now, when we look into the forest plot, two subset, premenopausal good, N2 disease, again, it was 1.19, which was probably causing unity. So N1 or N2, although the number of events are less in N2, but more or less we can tell that yes, even up to 9 node positive, if you are low genomic score, you can very well avoid chemotherapy. So the limitation was predominantly white population, and they took patients from 40 age onwards, 0 to 9. So less than 40, still we don't know whether this approach is feasible or not. And we don't know what will be, because now the standard of care in high risk early CA breast is addition of CDK4/6 inhibitor. So how would it have impacted our data? We don't know whether. So what this trial concluded is 50 gene tests can assist, save your adjuvant chemotherapy decision for premenopausal women, at least 40 or more treated with OFS, and patient, more importantly, 4 to 9 lymph node also, or stage 3A. You can avoid chemotherapy by using this approach. So gene expression signature allows safe tailoring of adjuvant chemo in postmenopausal women and in premenopausal older than 40 who received OFS. So do we have a data? So if you see, there are 4 studies now. You see your Taylor X study, 9-year IDFS, good. There is only difference of 1% when we use. When you look into our MINDEX study on the right side, 5 years distant metastasis, again the difference is less than 2%. And when you look into the third RX Ponder study, the absolute distance was 1.2% only. And this study, it was only 1.5. So probably we have 4 studies which states that yes, this approach is here to stay. Cost will always be a constraint, but if you follow this approach, all the 4 studies have suggested that there is no added advantage of chemotherapy. This study has used OFS, so probably the best study till date. Now in future, we have the data from one study from US, Offset, and in Europe, Optima Young, which will cover whether adding a CDK4/6 along with endocrine therapy. This will be important because now with CDK4/6, this is probably that thing which is discrepancy where what if I use CDK4/6, whether I further negate the effect of chemotherapy. But I feel in future, with all these things available, we will be more judicious in using chemotherapy, and endocrine with OFS plus minus CDK. Probably with CDK will be a way where we can avoid 60 to 80% of the patient taking chemo. So what did the author or the expert is? Yes, I'll recommend this genomic testing for all our premenopausal more than 40 or post with any number of lymph node. I think I'll be careful till N2. I think it is okay. And the low genomic risk score will probably, this will give us more time, and we'll be more discussing with the patient once this is available. So for me, yes, optimized study. We have still not got the NCCN category what we use for Oncotype DX, but now they are reviewing it, and probably in the next few months you will have this as an upfront thing. A good data and probably a more relevant data. The second study in early CA breast is, we know we have a drug, what we use is either an AI or a tamoxifen. What if I use third as a first line in an adjuvant setting? So what is this third? Giredestrant. Because so probably comparing giredestrant versus the standard of care AI or tamoxifen with OFS for 5 years in high risk patient. This we already have a data in this ESMO 2025 where it showed that there was an absolute gain of 2.8% with a reduction in the hazard ratio by 30%. Now, this was a subset analysis based on menopause. So I have just tried to summarize rather. So a big 4,070, stage 3 were 40%, stage 2 was 47%, around 80% had taken chemo, 80% were node positive. So more or less a high risk subset group. Giredestrant for 5 years, OFS is premenopausal, and AI first. So around 30 to 40% was, when we say was premenopausal, approximately 40. Now the endpoint was a 30% reduction in the risk of invasive disease-free survival with the absolute gain of 2.8%. So now they tried to look up whether it is what is the quantum of benefit in premenopause or postmenopause. So when you look into the hazard ratio 0.65, 0.74. So irrespective of menopausal status, the giredestrant continues to show the benefit. So they have tried to see IDFS and DRFI, distant relief free. In both of them, there is an absolute gain. Now, added advantage of giredestrant is a very low toxicity, probably again some degree of musculoskeletal. Try to look into pink 5.7, so lesser discontinuation in pre and post, and switching to other endocrine due to musculoskeletal is also half as at what for AI. So a good drug, better than probably in AI. But the thing is, when again you look into discontinuation rate in pre and post, 1.5 versus 5, 1.7 versus 4. So probably less discontinuation, more safer drug. The problem now is a very short term. When you talk about adjuvant thing, you need a OS, I think so, to get or to include it in your clinical practice. You have a follow-up of 32 months, which is still short. Maybe in the next 3 to 5 years, when we have a OS data, we might take it to our practice. But what I feel is when you have a CDK4/6, when you have a high risk subset, you may start your AI, give CD5 and maybe the future trials, whether you can sequence it with this giredestrant for those with very high risk of recurrence and maybe a N2 or NT. But the data now is small. Whatever data has come with the follow-up of 32 months, there is a gain of 2.8% irrespective of menopausal. Will I change a practice based on this? Answer is no. We need to wait. But yes, the data is impressive. So this was what that was given. Am I a new queen? Giredestrant is asking. So maybe a future will tell because I have a greater efficacy, no safety concern, and a improved treatment adherence. So probably future this will tell us more. The next two data in the last two because of the time is metastatic CA breast, hormone receptor positive, HER negative. So there were 3 studies that was discussed. Persevera, I won't discuss it. Sahu sir will discuss. Serena 6, again I will not discuss, with Sahu sir will discuss. And the third study which I will discuss is, this is a second subset of patients. So triplet in a second line in a HR positive. A PAM inhibitor, so PIK3, AKT, mTOR, gedatolisib versus a standard of care which is fulvestrant and alpelisib that we say that we know. So that is it. So giredestrant, just a short, persevera was a negative study. I am not discussing. So giredestrant had shown benefit in adjuvant, but not in a first line metastatic. This is a good topic to be debated. We all expected camizestrant to have a better PFS2 than PFS1. Whether it will change your practice, we'll discuss in the panel. The third study which I am discussing, which is the most important, is a Victoria study. This data is presented in all the presentation I see. Post progression on CDK4/6 inhibitor, the best drug in the second line is a third plus a different CDK4/6 inhibitor. That is what no. We have EMBER-3 data, we have Evera data, and Victoria 1 study also. Basically, Victoria study 2, in ESMO, it was a non-PIK3 mutant. Here, probably a PAM inhibitor in a PIK3 mutant, which was the second subset, they gave the first analysis. So we all know that this is a potent pan-PIK3 inhibitor. I think I'm excited about it when I discuss the toxicity. Now, when you look into the previous ESMO, 9.3 versus 2 months in triplet, 7.4 versus 2 months. So doublet, triplet, both shows a good efficacy against the fulvestrant group. So what was the study group? Progression on or after CDK4/6 inhibitor and second or third line. So 2 or less than 2 lines of prior endocrine, no chemotherapy. So the main thing was Jida palbo fulvestrant versus alpelisib fulvestrant. I think we should appreciate the authors because they have taken a standard of care in the other round. In the second line PIK3, it is alpelisib versus fulvestrant. I will always be interested in knowing about arm F, which did not contain palbo. As we know in terms of Paloma and study that palbo followed by palbo does not work, but still this was it. The primary endpoint was progression-free survival in arm D versus E. What is more important is 40% of patients had taken palbo before and now were continuing with palbo. And more importantly, all patients who are taking the second line has a good response in the first line. So if I have a patient who has progressed rapidly on CDK4/6 inhibitor, I may not give it in the drug naive. The drug has to work for at least 12 months. So a continuing CDK4/6 beyond progression for those patients who already had a response. C, D 17.5, F 22.1, E 18.9. That is more important thing. So a very statistically significant improvement in the PFS, 11.1 versus 5.3, statistically 50% reduction in the triplet. For me, this was a group which was beyond, which was not with Palbo. The quantum of benefit, I'll go back, 11.1, 11.3. This was not a primary but a secondary endpoint. So for my only problem or only thing which do we really require a palbociclovir? Because doublet versus triplet, the PFS remains more or less same, 51 versus 50. Now, objective response rate again better when you in the triplet 48 versus 35 versus 26. The median duration of effect in arm 2, 24.2 months. So thrice to 3.5 times in doublet versus fulvestrant versus alpelisib. This combination is safer. This is more important. So probably this drug is less toxic than alpelisib when you see the adverse event, treatment related and the adverse event in the E arm, last 13 discontinuation versus 4. Please concentrate on this slide, more important. Diarrhea is 15% versus 40% in alpelisib. Hyperglycemia 15% any grade versus 57.9% in alpelisib. So the two side effects that we worry in alpelisib was far less when you use this J-Dido combination. So a slightly safer drug according to me. So this was what they concluded, doublet, triplet better. Importantly, a safer drug with less of diarrhea and hyperglycemia, and probably it could become a standard of care. So what they took is J-Dido, Fulvestrant, double PFS, treatment discontinuation was less than 4%, and a first study, multi-targeted PEM probably may improve outcome compared to inhibition of a single target, that is PIK3 in alpelisib. This is probably what do you really require a PAL? This we don't have an answer, because if you see the E and F arm, J-Dido versus versus adding a palbo. So probably that is the arm where we have to see whether you really require, whether it only. Can I do a PAM in a first line? Because if you know that is fine. Or you start with alpelisib maybe and then targeted PAM in the second line, because you know that once you target one pathway, the alternate pathway gets upstage. So you might get a good PAM inhibition in the third line maybe. And more importantly, this drug has to be given IV day 1, day 8. So lot of things to be answered. It may not change my practice, but I know that there is a drug which works equally potent like alpelisib, or maybe better as per as the doublet data. The last part, we have a data of 3 to 6 monthly zoledronic acid versus monthly to save the cost. So this study was, can I give a 3 monthly denosumab instead of a monthly in a metastatic carcinoma breast or colon? So a non-inferiority study, first 4 months monthly, then followed by every 3 monthly denosumab versus monthly denosumab in arm A. So please remember, high risk group, more than 10 bone lesions in 57%, prior skeletal event was there in 50%, a bigger trial. So what did trial? It tried to find out symptomatic skeletal event. Was it a relevant endpoint? Yes. Absolutely bang on, 56.6 versus 56.5. So there is absolute no difference in the first skeletal related event, but where it scores is time to first hypoglycemia, time to first osteonecrosis, time to first osteonecrosis to tooth infection is statistically lower when you give a 3 monthly. And more importantly, for a country like India, there is a reduced financial toxicity. So I think the most relevant studies I was using sometimes, I will be very sure, but now I'll be more sure because I have a data. What are the pivotal studies in eye? So try to look into the study. If you have time, I'll not close. These are the studies which suggested that the skeletal related events, as you see, as you are using these potent drugs from 3.7, it is 0.45. And when you are using now, the skeletal related events are only 1.13 and 0.4. So probably it is due to better systemic anti-cancer that we are using. So there may be a point where probably for some low burden disease, can we omit this drug? Because our systemic therapies are so good, it may negate any bone modifying agent advantage that we have. But at present, yes, with this data, I can use a 3 monthly drug. So 1 minute, why it is. Yeah, so last part, two drugs that I needed to mention. I'll not mention anything now. The future is not for monoclonal, but it is for biparatropic and what we say bispecific. So in a HER2 amplified neoadjuvant, we had one drug called as N-bentamab. It improved your PET-CR against control of THP, so trans-THP from 51.2 to 62.4. So probably in future we may have this data against TDXD, which has the best PET-CR. And the second drug which I am more excited, which is a bispecific with Isabren, isolantamab brengitecan, Panku study which showed that your PFS improved from 2.2 to 3 months to 8 to 9 months in those who had progressed on first line treatment, which included 30% of patients post IO in the first line TNBC. So this drug will probably be one of the good drugs which will be competing with the standard of care, including Sekituzumab or everything in the second line. So we are in for exciting data in the future. So what are my take-home message for the 4 studies I mentioned? Optima, yes, for me, 50 gene Prosigna data impressive. We may start using it more so for N2, where we were worried about it. Now we have a data. OFS was used, which I think was a game changer. Adjuvant giredestrant, impressive data, 2.8% absolute gain, but too early to predict, which may change the practice maybe. But yes, the data is good enough. 12 every 3 monthly denosumab is non-inferior to every 4 weekly regimen. We have seen bang on skeletal related event, but lesser toxicity. And a pan-PAM inhibitor, gedatolisib, it is again a new option in HR positive MBC, but whether future trial will decide whether you sequence it first alpelisib or you give it upfront, probably, because for me this is a drug which has worked better than alpelisib in the second line, but again that was never the part of this trial, so you should not get carried away with it. It was a triplet which was the primary endpoint and that showed better. So the third drug, whether it is required, we can always debate when Saucer is there, who is the best, I can say by far the best who can conduct a panel, and always a privilege to watch Saucer. So I end my talk with one of my favorite slides. The secret of change is to focus all your energies, not on fighting the old, but on building the new. I again thank Somani sir. Sir, thanks for a kind invitation. And I give the podium back to the organizer. Thank you all.
Thank you, Dr. Bharat, for such an excellent presentation as always. Now, I think the next important is we have Dr. Sahu with us. Good evening, Dr. Sahu. Thank you so much for joining. And everyone is looking forward for the panel discussion. You have all your panels with you. So over to you.
Thank you.
Pooja,
Can you just
allow sir
please
to
allow.
use slide. Yeah, over to you, sir. All yours.
Okay, sure. Just give me a minute. Yeah. Thank you, Dr. Naresh and the team for inviting me. And I think we are starting at 9:15, so 20 minutes. So someone please tell me at 9:35 that we have to stop. So thank you again, Naresh sir. And thank you everyone, for the panelists for joining this late on today. So these are my 5 panelists, and as I've been told, all of them are there. So we'll move forward. So I'll go to 2 data sets, and then if time permits, I'll go to the third one. So this is my thing, because 20 minutes is not a big time. So I'll go to one which Bharat spoke about, is a negative trial, Persevera, and this is a negative trial. So I'll tell the trial design is very, very clear that it was a giredestrant plus palbociclib plus letrozole, which was taken up, and that was being considered against a doublet that was and we just needed to see what exactly is happening, and this is the design exactly, the giredestrant plus minus the placebo and the palbo versus letrozole. So basically take home should be that the palbociclib is constant and we are only replacing the letrozole with giredestrant and trying to see whether the addition of a SERD does make a difference. And the primary endpoint in this study, as was very clearly mentioned, was PFS. And the secondary endpoint, very important, was OS, response rate, and the quantum of clinical benefit. So, Dr. Rakesh, do you think it is practice changing? As Bharat told already, it's a negative trial. Do you find some positivity? If it is not, and can you tell me why do you think it is not, why it turned out to be negative? Because Resistant was a positive trial in later lines. We saw that in ASCO 2025. So why do you think this trial was negative?
So, not decided whether what are the criterias. They are too common. So maybe some particular subset which is more beneficial in with this particular drug, the drug is good. But as Bharat had said, ki it's too early to comment on for the practice changing pattern.
So
Maybe
you,
a promising thing, but it's too
so
early to
so
change it.
any ideas why it turned out to be negative? Because Resistant was positive in the later lines. What happened that it was not positive in the front line?
So it's to explore some of the subsets where it is beneficial. Maybe some
Okay.
particular things.
Okay. So Sandeep, anything you want to add? Jasuja?
Yes, sir.
Yeah,
So
please. Boli.
key point is that it's not a practitioner. I agree with them, but it's a biological interesting but statistically negative trial.
Mm-hmm.
So why the points are not, why it's not statistical significant? Because the effect size was modest. If you look at the median PFS, it is only 4.9 month difference.
Mm-hmm. Mm-hmm.
One thing. Second thing, confidence intervals crossed one. If you look
That
at
is
the
that is why it is negative. That is why it is
yeah.
negative.
So that's
So
why
my,
it's a clinical, it's a interesting, it's a biological interesting, but not
okay.
statically, but it's a
Okay.
statically negative trial.
Okay. Ananya, any points, anything to add? Very specific. Why do you think it is negative?
Yes, sir. Good evening.
Hi.
So actually, we already have such robust data with palbociclib. Secondarily, these patients upfront, they are already hormone sensitive. There
Okay.
is not much resistance. So I think that's why adding giredestrant in this setting didn't
May
add.
not have worked. Okay. So basically there are two, three things. I think Ananya spoke with two, three things, and Rakesh and Sandeep wanted to point out fewer things. We'll come to that. But very clearly, I think Ananya's point is very valid that if you look at the eligibility criteria and look at the eligibility criteria, very, very clear that this was a very clear upfront patients who were treatment naive actually in the metastatic setting. So that's point one. Point two is they should have been at least more than 1 year disease free from adjuvant treatment. So basically, they retained their hormone sensitivity. They could only be receiving tamoxifen, and early relapses were taken if they had taken tamoxifen. Does this thing, Preeti, is important to you that for tamoxifen they had used this 12 months criteria, and for AIs they had used more than 12 months? So, do you think anything is different here?
Yes, of course, it is different. And for
Why
AI,
do you
they
think it
have
is
used
different?
for
Why do you
AI
think it matters?
for AI because they have chosen the patients who have progressed on AI more than 12 months, and
Mhm.
the patients who were on tamoxifen, I think they were just 10% or so,
Yeah, they were
and
10%.
so the numbers to signify that as very very less.
Okay, I'll put a counterpoint. Why it is important for me when I look at the concept of we are doing a SERT. And when we use a SERT, we have seen the activity in the second line, and we did find that Resistant looked very good and did very nice for the ESR1 mutated patient. And if you look at the ESR1 mutation, how it goes through, it's mainly seen in patients who are refractory or has at least had a decent exposure to AI. And the most of the ESR1 mutation happened between the 6 months to 32 months. The tamoxifen, post tamoxifen, the chances of developing ESR mutation is very low. In a post AI, it is around 40-45%, maybe 30-35. That's where the range is. But in a tamoxifen post exposure, the chance of getting as ESR1 mutation is around 2-3% or very, very low. So basically, my point here, which I wanted to make, which Ananya started off, is this: we are dealing with the patient who were not having ESR1 mutation. I'll put it more very clearly, where the drug would be more active. Second, what she told was that already you have a landmark of the trials which are already very high, because letrozole or anastrozole plus a CDK4/6 already have reached that 24 years mark for PFS. So the 24 months mark is a very high standard. So beat that, you need something very, very powerful. So Bharat, any quick points on what has been already discussed? What I
Sir,
really
fully
meant
agreed
was,
with
yeah,
what I said. Sir, I
yeah,
have one more point to put. Maybe we had a discussion.
yeah,
Now you told correctly that ESR1 mutations are those where this drug works. So probably the patient profile that they took was more of a bad profile. So visceral mets was more though. We all
yeah.
know that with the de novo visceral they progress rapidly. So probably the maybe that is also a afterthought, but the patient population that they took inadvertently were those which progressed rapidly and probably had a lesser chances of developing a ESR mutation in future.
Patient population which they took actually were chemo endocrine sensitive. Chance of getting ESR was actually very, very low. So that's what the
And
point
visceral,
all of us are.
non-visceral was so bone only was only 10%. So
Yeah,
probably if probably those subset would have been more, we would have got more of a ESR and probably this trial would have been positive. Again, afterthought.
exactly.
What
And
So this is
I have put few
yeah, Naresh
points in
bhai,
the chat
boliye.
box.
Yeah,
I have put a
please.
few points in the chat box.
Okay, I'll just, because I'm not able to see the chat. Can you tell me exactly what exactly do you find
So
very, very
even if
pertinent?
there could have been the 2-3% difference, today we all believe that the abemaciclib or the ribociclib have shown the overall survival gain, contrast to the Paloma trial or the palbociclib based trial. So this is being pitched against the Letro plus palbociclib, so probably of no use. Thanks that it has not shown any benefit. Otherwise, again, it could have put some controversy that what to do.
Okay, I'll take it some other day regarding that, because we are looking at PFS, and I think PFS was uniform for all the three drugs. Why Abima, why Ribo was positive, we can discuss some other day, but I think so on the PFS point, all the three CDK4/6 are similar. So I think the quantum of benefit on the PFS is actually same. So we'll go to
I
anyone
have
can
one
take
more
it.
point here.
Yeah, Sandeep,
And
please tell
even
me.
resistant early progression may be driven by non-ER mechanisms. So simply replacing
I
AI with SERD may not overcome early CDK4 resistance. So that's
Okay,
why it's not it's a negative trial.
perfect. So, any points, Bharat? Why do you think this graph actually started separating, and the separation has been very uniform post 1 year? If you see, there's no separation post 1 year, and post 1 year, although clinically, statistically insignificant as was spoken about, you definitely see the graphs separating, not crisscrossing, and the separation is being maintained. And the and the delta, if you look at it at the later point, is around 3 to 4%. It is not. It is what you normally see on which we based our AI versus tamoxifen data. Any points? Any thoughts?
Sir,
It's
the
probably
early progressor, once you remove, those patients who respond well may respond well for a more duration of time with Geragestan, what I understand. So
Okay,
whatever
and
mutation.
someone else was making a point.
So
it's probably we are getting ESR1 mutation at
yes,
this point
Perfect.
of time.
That
yes,
is probably the most
two
likely
several
reason,
reasons.
because
Yeah,
post 6 months you start getting it. That's where the drug is active. That's where it was
active.
active
Yeah.
in second line. So this could be one of the reasons. Not tested. Only when the full paper comes out, we have the supplement data. We can get more data. That's what I also feel. That's why you see that clinic, that things really happening. Okay, so this was the discussion slide which I've taken from ASCO, and that is the hypothesis that probably we enrolled patients who are less likely to benefit from a SERT, and the alternative mechanism of CDK4/6 resistance not addressed was spoken by Sandeep and backed by Bharat. Second point, in contrast to little what Bharat spoke, something more to what I'm talking, but Bharat also spoke something different. If you look at this meta-analysis, this has been there for quite some time. Again, I borrowed it from the discussion slides. This one thing comes out that SERD is very much active for non-visceral disease. And this is the reason why why Bharat spoke is these are the patients who are very likely to develop ESR1 mutation. You have more chances of developing ESR mutation in the bony metastasis patient rather than in the visceral mets. This could be also one of the reason why in the persevere also you find, although I would not read the statistic like that, but you see a little bit more forest plot favoring towards the non-visceral. So this is just a point which I would just wanted to highlight. So last thing, Rakesh, this is one point which I wanted to make out is can this trial be also seen as that is there a subset of patient in your practice whom you think that you can start a CDK4/6 later on, just give a hormone therapy in the front line and also start the CDK4/6 in the second line, and you still will not be compromising on the survival. And I hope you got my question, Rakesh.
Right, sir. So this study holds true for the patients who are postmenopausal. There is no difference. But premenopausal, when you use upfront, that makes a difference.
Okay, this is actually a Sonia study. All of us know this, that first line versus second line, a CDK4/6 did not matter for survival. But if you look at it in the post-hoc analysis, actually, if there is a premenopausal versus postmenopausal, and you look at it, the premenopausal patient benefited from the front line, while the postmenopausal did not. It did not matter whether you give front line, second line. This is just an indicator. So is it that in some patients you can just go away and do this point of a single hormone therapy, mainly in the postmenopausal, maybe in the boni meds as was spoken, and then reserve the giredestrant and the CDK4/6 to the second line is a discussion for some other day. That's where I also feel we would be having more data. Bharat, any points on this?
No, sir, excellent. Well, you have rightly summarized everything. That probably if it would have been more of a bone meds only, this might have worked. And that gives us a thought to understand that
a little
probably
more profile of
everything
patients
ESR1
observed.
dependent. Yeah, agree,
Okay.
sir.
Preeti, Serena-6, excellent data set, excellent concept. We have been hearing about Serena-6 for last 2 years.
Yes.
Discussing and criticizing. Some people actually loving this way of mechanism. If you look at PADA-1, which was read out 3-4 years back, again it was a positive data set, although PFS was positive, OS was not there. We don't have a OS for Serena also as of now. But what do you think? Do you think Serena is practice changing?
Presently, I don't think so, sir. I don't think
You
Serena
don't
is correct.
feel so.
Yes.
And Ananya, practice changing for you. If finances is not a problem, you have the richest person in your clinic of the city coming down to you. Do you think it is practice changing?
Sir, in the coming time, yes, because the PFS improvement was quite good. I think nearly double 80% PFS improvement. That is a good data. But
So you feel
as of now, sir, if the patient is willing and educated,
yeah, patient is willing. Patient is willing for the concept. Would you like to do that?
sir, yes, in some patients I would like to do that because
Okay,
it's an impressive.
some patients, who are those patients again, except for deep pockets? That is
No, sir,
given.
no, not like that. But some patients, they are not willing to go for again testing, and plus this drug is, of course, it is not available as of now in India.
Okay,
But
now
in
we
the
will assume
future,
it is
I think,
available. We will assume it's available. Then only it makes sense to discuss this.
sir, I would like to give a chance, definitely.
You would like to give a chance, and that's fair idea. Rakesh, yes, no, practice changing. Would you like to? Although we don't have data from India and or Indian approvals, but would you like to give it to choice to a patients?
Choice, yes, but
Choice, yes.
not very much interested.
Choice, yes, we are very much interested. दोनों जगहों पे पाव रख दिया तूने. Anything, मतलब, are you convinced of the
No,
data?
sir.
Not
As long as sir,
Bharat, I'll come to you. I'll come to after Sandeep Jasuja. I'll come to you. Rakesh, are you convinced of the data?
I'm convinced.
Okay, you're convinced. That's fair enough. Fair enough. In the ODAC committee, it was defeated by 6-3 votes. So 3 oncologists of world stature were convinced, Rakesh. No issues about it. Sandeep, yes, no.
Sir,
Convinced of the data, or there are some flaws still? Suja is there? Or we lost him? Yeah. सर हम आपको सुन नहीं पा रहे हैं सर. बोलिए प्लीज. संदीप भाई बोलिए. आप हम सुन नहीं पा रहे हैं आपको. We are not able to listen.
vote as a rejection of Kamajli show that the CTD after emerging ESR1 mutation. I will not interpret the ODAC. Sir, can you hear me?
Yeah, आप बोलिए. Are you convinced of the data? Quick yes, no.
Okay, sir. I would not interpret the ODAC vote as a rejection of this Kamaji standard activity.
So you
Serena
are
6 clearly
convinced of the
showed.
data.
So,
You are
sir,
convinced of the data.
sir, add not, and because this is based, the ODAC committee rejected on the some evidence base. If you
Forget the
don't,
ODAC committee. I never asked that. I asked, are you convinced?
Yeah.
Are you convinced?
No, sir. At present, not.
No. Okay. Bharat, any reasons why there is a division also? ODAC, there was a division
If
of
you look
votes.
into AMBER data, which suggests that when there was a radiological progression, giving this drug with a different drug with a different CDK, you still went to a PFS of 11 to 12 months. So if you add on the first PFS and second, probably it will be better. This is a good data, but not a practice changing. Practice changing when will be when you will have a OS advantage. At that time, probably we did not have a data to say that post progression or giving early. Now we have a data to say that post radiological progression.
We have only 3 minutes, so I expect my panelists to be very crisp and short. If we have to be very short in this.
Sir, the same benefit will come once there is a radiological
Okay, I
progression
understand.
as
So
per as AMBER
basically,
data.
you are
Yes.
telling me
We
that
can
if you give it
start on
in
radiological
progression,
sir. Even we
then
can start after
also you
radiological
will
progression
not
with
lose that benefit of survival. That's what I'm
Yes,
getting
sir.
from you.
Yes, sir.
Okay. Okay. So now Ananya and Rakesh, I think both of you need to convince the others, and I'll ask you 2, 3 points where you need to just be clear. And I think both of you are very okay with that. So point is ODAC voted 3-6 to 3, and it will go for a final decision. I'm pretty sure this approval will be coming. I don't know when, but it's coming very soon. It's a novel approach. All of us agree. The quality of life indicators were superb. Even if you're giving a camizestrant, the toxicities were not there. That's something people would remember. The quality of life data were excellent. PFS 1 and 2 both were better, and also the time to receive chemotherapy. So this is something that is in advantage with it. So if you look at the point, yes, the criticism, Ananya, I have a patient, 100 patients in a practice. If you go on doing the ESR1 mutations, if this approach is there and approved, 15% of the patient will develop a ESR1 mutation, maybe 20%. And of these, 10, 15, nearly 30% will be excluded because by the time they have a ESR1 mutation, they have a radiological progression. I hope you're getting the point. Because Serena 6 excluded patient with coexistent radiological progression, only ESR1. And once you do that, you have a delta of around 6 to 7 months of giving and continuously monitoring versus giving on progression. Am I clear, Ananya?
Yes, sir.
Okay, so now this is the data set actually which Bharat spoke about. And this data set is very, very interesting. And this data set tells you 2 things. If I give a single agent SERD, I see that there is an initial dip of around 30% to 35%. So these patients do not respond to SERDs also. Sharp dip in 2 months. Once you start giving imlunestrant plus Abima, like a SERD plus CDK4/6, this dip decreases to around 15%. So you're able to salvage around 50% of patients. And look at the median PFS, it is around 11 to 12 months in the UMBER 3. And the only SERD gives you a PFS around 5 months. So you have a delta of around 7 months right here itself, which is exactly the data with Serena 6 you see. So can I be justified in delaying till the radiological progression and then giving the drug as Bharat told and giving it with CDK4/6, not SERD alone? What do you think? Is it anyway unjustified?
No, sir. I think it is along with CDK4/6. If we are giving, then I think the data is good.
I think the SERD alone era is gone. I
Yes.
think the newer combination, if you see for last 1.5 years, is a combination with SERD will be the future. A doublet or triplet, I don't know. So Rakesh, any thinking that Serena 6 is an expensive protocol? It will create anxiety probably. It will be something I can just match up with the PFS and I don't have a survival benefit. Would you think this approach is justified, Rakesh? Rakesh?
Have to comment on, sir.
Please, Rakesh, हम सुन नहीं पाए. Please, can you come again?
tough to comment on, sir.
Okay, tough to comment. Okay, I'll make one more point and probably stop because we have just reached the time period of 20 minutes. If you look at the third curve, which is the Serena curve, and I want Bharat to have a point, and anyone can come in, even Naresh Bhai can come in. So first, which I showed was the first thing, which was a single agent cert. You have a 35% loss. So the approach which Bharat suggested, which something that world is talking about, that on a radiological progression, give a cert plus CDK4/6, you are going to save around 50% of those early progressors, and your delta of 6 to 7 months, you're getting it. But look at the Serena curves. They start separating from right point 0. There is no dip actually in Serena on PFS. So Bharat, my question is to you, will a day be coming that this 20% which are progressing on number 3, the early progressors, and these early progressors are those which are probably can be salvaged by the Serena 6 approach. I hope you are getting my point now. So we salvaged 50% just by giving a CDK4/6. We are still not able to salvage 15, 20, 18% who are early progressors. That dip is still there. And in Serena 6, that's not happening. Can we salvage these patients? And if we can get to know who these patients are, then the world will be much smoother and much more easier. What is your take, Bharat? My
Yes,
last question.
sir, whatever you said is absolutely correct. This subset is what we need to find out, sir. Because probably when you get a drug for this subset of patient, the overall outcome will improve. So for me, how to improve, I don't know, sir. But yes, that is what you said is correct, sir.
So this is what my thought was, and I looked into this data set, and this is something which I did not borrow. I just put forward this number 3 data was there already, but I wanted to see these curves, and you see the dip not happening. So they will come when Serena 6 will note and identify the patient which were refractory number 3. Probably those will the patient where Serena 6 will be an approachable thing. This is something that is what I felt about. So Naresh bhai, I'll stop here because it is 20 minutes and I will not go into Victoria. Just one question. If you can answer that, or Bharat can answer, because they took Victoria 2 study. Victoria, Bharat, you spoke about that the addition of the gedatolisib. Yeah. And the CDK4 is a triplet versus doublet. I just have a question because the trial, it looks like the doublet and the triplet, there's no difference. Am I clear?
Yes, sir.
So do you think that the future is the doublet and not the triplet here? Or you have a statistical query on this?
Sir, provided the only thing is Palbo followed by Palbo may not be the right approach. Maybe a future trial should have included a Abima with this. A Palbo with Abima with a doublet, probably that would tell. But for now, I think doublet is good to stay. Future might tell whether you should use alpelisib before or gidadolisib, because if you see the
I have 2 points quickly. Anyone in the panel wants to say 2-3 points on this Victoria dataset which Bharat presented? Last question on this. Anyone? Ananya, Preeti, or Rakesh? Because I have 2 points to say after you say. No? Okay, I'll tell you 2 things. Guys, look into it's my thought process. I may be wrong here. The point is, when you look at the class randomization, is a 3:3:1. You have to remember that it is 1/3 of the patient which were randomized to the triplet versus the alpelisib and fulvestrant arm. So you had around 55 patients only in the gedatolisib and fulvestrant arm. So arm F had only 55 patients. Remember, the point here again I go back to is when I look at statistics, was it statistically significant to come to a conclusion that the doublet is as good as triplet? So point here is you do not have a statistical analysis of T versus E. Point 1. Point 2 is you also, if you look at this thing, which people many times miss the statistical analysis, the arm E and F analysis was not part of the primary efficacy analysis. So people have to remember, my question is, was it statistically powered to answer the significance of the doublet of gedatolisib and the alpelisib doublet? I'm not sure. The randomization 3:3:1. And there is no powering for the triplet versus doublet of gedatolisib, and also the doublet versus doublet was not there in primary analysis. So that is one point. Second point which really bothers me is the response rate criteria. If you look at it, the objective response rate of a triplet is much better at least delta of around 13% to 14% than a doublet. And you would like to have a statistical significant benefit with a more response rate. That is where I feel that here in this Victoria, the triplet is going to be the winner, not the doublet. Same thing what happened with the study one actually. The triplet was something that we are looking into the study one also. So here also, because of the reason I mentioned, I feel triplet is going to be the way forward. That is my small thinking. Till the whole paper comes out, I don't know how much of my thought process is correct.
Sir,
So
with the same CDK4/6 or different, according to you? Triplet with the
see,
same
point here is why they've used palbociclib. People have to remember palbociclib because people have to
Sir would
remember that.
request to conclude.
Yeah, I'm concluding. Palbociclib because it is important that it is much more safer as a point. And if you look at it, the other 45 and 16, around 60% in this had already received a ribo or abema. So all that post monarch and everything had majorly those palbos. So this is more of a combined population. So I don't know exactly that question answer, but I agreed that CDK post CDK has to you better to change the CDK. That's something. But genatolisib, if you look at the count, the toxicity, you have more neutropenias also. So please be very careful when you change the CDK4/6. So that's my small take. I won't go take more time, and I'll go to my conclusion slides. Serena 6, concept of activity, yes. Concept of change at molecular only progressive disease, we spoke about. There are open questions. Is it ready for clinics? Two of my panelists thought they will start discussing. At least no for me and two other panelists. Third, with CDK4/6 in the front line, not ready for prime time use. We spoke about that. Victoria data looks good because the PFS has doubled. We had never seen this PFS doubling from 5 to 11 months. Triplet for me, because of the data things I spoke, looks to be the go-to protocol. PFS2 I am not touching because that was for some other day, some other time. Is PFS2 a good endpoint? And is PFS2 a surrogate marker for OS? Some other panel discussion, I'll take this up. Very nice data set actually. So with this, I'll conclude. Any panelist has to say something. Any panelist has to say some point. Otherwise, I give it back to the organizers.
Sir, you are very excellent as always. The best for a panel. Durandar for us.
Thank you, sir. मेरे को अब गदगद मुझे लगने लगा है पूरा.
Thank you, sir. A very excellent
Thank you, sir.
presentation. Very excellent moderation. Thank you very
Thank you.
much, sir.
Thank you, Dr. TV Sao, sir, and thanks to all the panelists for the excellent panel discussion. And we move to much awaited session of today, the quiz. And our quiz master for today is Dr. Ananya Parekh, consultant medical oncologist, Renova Hospital, Jaipur. And I would also like to invite Dr. Ankur Shah and Dr. Somnath for conducting the quiz. Over to you, sir. Over to you, Dr. Ankur.
Shall we start?
Yes, sir.
Yeah. Good evening and a warm welcome to all of you. I am Dr. Ankur, part of medico marketing team of India. Quiz day 2 of 7th BCOS 2020. Can we have the screen? Yes. So let's have some fun to play and participate in this quiz. Please download Kahoot app. Easy to download app. It would just take 30 seconds. Available on your Play Store. Your mobile phone would work as a keypad to punch in the right answers. Please log in with your full name. No nicknames. No short forms.
Dr. Sandeep D'Souza would request you to unmute yourself, sir.
Log in with your full name. No nicknames, no short form. There are 11 questions. Each question has 4 options. You need to choose right and you need to be quick to score the maximum points. You get 45 seconds to answer each question. After every question and answer, will have expert comments from Dr. Ananya. To participate in this quiz, enter game pin. Game pin is on the screen, 2410499. You can even participate by scanning this QR code. Please log in with your full name. No nicknames, no short form, please. Winners take away exciting prizes. I can see the excitement. Yesterday, the winner was Dr. Manoj. On the first position, he had 11 out of 11 right. Somebody has login with initials, Dr. Wa. I would request kindly re-log in with your full name. Dr. Manoj has logged in. Dr. Amit has logged in. Dr. Amit was on second position yesterday. We have 19 participants so far. Couple of more minutes to go, then we start. We also have Dr. Faiz. He was on third position yesterday. Will we see new winners tonight? A minute more to go, then we start. Somebody has joined with initial SK. I would request, please log in with your full name. Shall we start?
Yes, sir.
Okay. So let's begin. 3, 2, 1. Here we go. The first question on the screen. Which of the following statements is not true about Harmony 6 trial of ivonescimab in non-small cell lung cancer? Option A, ivonescimab plus chemo showed significantly better OS. Option B, OS better with ivonescimab plus chemo consistent across PDL1 expression subgroup. Option C, grade 3 adverse events were higher with ivonescimab plus chemo. Or is it option D, the trial had patients non-squamous non-small cell lung cancer with no prior systemic therapy and no drive mutations? And the right answer is option 4. But the house seems divided. Yes, Dr. Ananya.
Yes, so Harmony 6 was one of the most discussed trial in ASCO 2026, and it has used ivonescimab, which is a dual bispecific VEGF with PD-1 inhibitor, and it specifically used the patients who had squamous NSCLC with no driver mutation.
Let's see the scoreboard. We are seeing a repeat of last night's quiz with Dr. Manoj leading from the front from the first question itself, followed by Dr. Amit. Dr. Harshad is on the third position. Let's move on to the next question. Second question on the screen. In the Harmony 6 trial of ivonescimab plus chemo, what was the control arm? Option A, placebo plus chemo. Option B, tislelizumab plus chemo. Option C, serplulimab plus chemo. Or is it option D, toripalimab plus chemo? The newly launched immunotherapies in Indian market. 20 seconds more to go. Most of them have already punched in their answers. To score maximum, you need to be right and you need to be quick. 10 seconds more to go. The right answer is option B, tislelizumab plus chemo. Yes, ma'am.
So yes, unlike other studies previously which were using the control arm as a previously standard of care therapy with placebo, this study, that is Harmony 6, it has used the PD-1 inhibitor immunotherapy, that is tislelizumab. So I think it is quite exciting as a clinical point of view.
Exciting study that has been done by having a comparator arm of tisli plus chemo. Let's move on to the scoreboard. Will we see a change? It remains the same. Let's move on to the third question. Where is Dr. Fairs tonight? Third question on the screen. Harmony 6 trial endpoints were option A, PFS and OS are dual primary endpoints. Option B, PFS was the primary endpoint. Option C, OS was the primary endpoint. Or is it option D, none of the above? The question is regarding endpoints of Harmony 6 trial. That was quite quick. The right answer is PFS was the primary endpoint. Yes, ma'am.
Yes, so PFS was the primary endpoint and the OS was the secondary endpoint, and the PFS was 11.6 months versus 6.9 months with an impressive hazard ratio of 0.66 and a very impressive p-value, that is 0.0017.
Statistically significant outcome was shown in this study. Let's move on to the scoreboard. Will we see a change? Yes. So Dr. Faiz is back in the race. He's on the 5th position. Let's move on to the next question. Fourth question on the screen. Which of the following statement is true? Option A, Harmony 6 trial included global patient population. Option B, Harmony 3 trial included patient population from China. Option C, Harmony 6 trial showed better PFS benefit, ivonescimab plus chemo versus tisli. Option D, Harmony 6 trial showed good PFS benefit. That was quite quick before I could finish the options. The right answer is option C. Harmony 6 trial showed better PFS benefit, ivonescimab plus chemo versus tislelizumab. Yes, ma'am.
Yes, so we have already discussed that it was 11 months versus 6 months, but it is the first study to outperform an already existing PD-1 inhibitor regimen. So I think it is quite good to see the future of this drug.
Yes. Let's see the scoreboard. No change. Let's move on to the next question. Fifth question on the screen. The patient population enrolled in the LID-ERA trial primarily consisted of option A, HER2 positive metastatic disease, option B, triple negative breast cancer, option C, early stage HR positive HER2 negative breast cancer, or is it option D, male breast cancer? The question is regarding lead era trial. So everybody seems to have selected the right answer. So this is for the first time since the start of the quiz. Everybody is right. The right answer is option C, early stage HR positive, HER2 negative breast cancer. Yes, ma'am.
Yes, so we have seen it in the previous discussions as well that it has used giredestrant in the metastatic early stage breast cancer as an adjuvant setting, and the results were still evolving. So we would like to see the more data regarding this.
So the more data is needed before we decide. Let's see the scoreboard. No change. So Dr. Manoj has answered so far all the questions right. Sixth question on the screen. What biomarker was monitored serially in the Serena 6 trial? Option A, HER2 amplification. Option B, BRCA mutation. Option C, ESR1 mutation in ctDNA. Or is it option D, PDL1 expression? The question is regarding which biomarker in Serena 6 trial. 15 seconds more to go. Everybody is right once again. The right answer is option C, ESR1 mutation in ctDNA. Yes, ma'am.
So now Serena 6 is quite widely talked about study, and they have tested ESR1 mutation every 2 to 3 months monthly, and the results PFS benefit was there, and it was 16 months versus 9 months. So I think it is an upcoming data and upcoming practice changing trial, not as of now.
Okay. Let's move on to the scoreboard. No changes. Let's see the next question. We are halfway through our quiz. Seventh question on the screen. Which trial reported primary results of adjuvant selpercatinib in stage 1B, 3A, RET fusion positive, non-small cell lung cancer? Option A, Liberato 432. Option B, Crown. Option C, Chrysalis 2. Or is it 20 seconds more?
Everyone is right.
The connection is lost.
Right.
Good sir, we cannot hear you.
Ma'am, your
Yes, I'll add that Liberto 432 is definitely a practice-changing trial, as it showed it evaluated the event-free survival, and there was 91.5% versus 61% of the event-free survival benefit was seen with adding selpercatinib in the adjuvant setting in 1B to 3A RET fusion positive NSCLC.
Let's move on to the scoreboard. Am I audible?
Yes, sir, you are audible.
Yeah. Okay. So we do not have any changes, but we have a change in the third position. Dr. Deepesh is on the third position now. Let's move on to the next question. We are halfway through our quiz. Eighth question on the screen. Selpercatinib targets which molecular alteration? Option A, KRAS G12C. Option B, red fusion. Option C, MET exon 14 skipping. or is it option D, ROS1 fusion? And that was quite quick. The right answer is RET fusion.
So, before Liberta 0432, we had Liberto 0431 study, which has shown a consistent PFS benefit with a very impressive hazard ratio with nearly 81% reduction in the risk of death.
Let's see the scoreboard. So Dr. Amit has a streak of 8 correct answers in a row. Let's move on to the next question. This is third last question of the quiz. Which study demonstrated a 7-year PFS rate of 55% with first-line lorlatinib? Option A, Crown. Option B, Libretto 432. Option C, Flora 2. Or is it option D, Mariposa? The right answer is option A, Crown. Yes, ma'am.
So, 7 years updated results were shown at ASCO 2026 of Crown study, and as of the cutoff was October 2025, and 44% of the patients, that is 66 out of 149, were still receiving lorlatinib. Hence, the 7-year PFS benefit is 55% versus 3%, and the hazard ratio is 0.19, which is the best till now. We have seen the survival in ALK positive lung cancer.
So for patients of ALK positive lung cancer, lorlatinib has the best survival rate benefit. Let's see the scoreboard. And there is a change in the 4th position. Dr. Faiz has moved up the ladder. Let's move on to the next question. Second last question of the quiz. Rosetta Lung 02 evaluated which novel agent combined with platinum chemotherapy? Option A, ivonescimab. Option B, selpercatinib. Option C, pumitamig. Or is it option D, daraxonrasib? Question is regarding Rosetta Lung 02 trial. Oh, the house seems divided. The right answer is option C, pumitamig. Yes, ma'am. The reason for confusion.
Yes, pumitamig, I'm not talking in detail about it because the next question is regarding this only. So pumitamig is something to look forward to, and they are investigating pumitamig opposite to pembrolizumab, which is, I think, the first one, because pembrolizumab has made its impact and everyone is like quite well aware of that.
Okay. Let's see the scoreboard. Will we see a change? Oh, for 4th and 5th position, we are seeing constant changes. So last and final question. Will we see a change in top 3 positions? And the question is on the screen. Pumitamig is best described as a option A, RET inhibitor. Option B, KRAS inhibitor. Option C, PD-L1 VEGF-A bispecific antibody. Or is it option D, ALK inhibitor? The decider. And that was quite quick. And the right answer is PD-L1 VEGF-A bispecific antibody, pumitamig. Yes, ma'am.
So now Rosette Lung 02 is studying this pumitamig opposite to pembrolizumab plus chemotherapy, and ivonescimab was tested in the Chinese population, and this Rosette Lung 02 study is a global study which will include the population outside of China. So I think the data would be quite interesting, as we can implement it in our Indian population as well in the squamous cell lung cancer.
Yes, very true. So let's see the scoreboard. Will Dr. Manoj lead again? The day 2 of ASCO discussions. 3rd position, we have Dr. Dipesh. For 2nd position, once again, we have Dr. Amit Kichlu. And for 1st position, for 2 consecutive days, it's Dr. Manoj. For runner-ups, we have Dr. Arshad on 4th position And on 5th position, we have Dr. Faiz. Congratulations, winners. I hope you enjoyed this fun way of learning. Thank you, Dr. Ananya, for your expert comments. We learned a lot from it. Thank you so much, Dr. Somani sir and Dr. Sharma sir, for giving Intas this opportunity. Over to you, sir.
Over to you, sir.
Thank you once again, Dr. Amit Ankur Shah and the team in task. And a special thanks to my colleague, Dr. Ananya Parikh, Medical Oncology from City of Jaipur. And thanks to all the panelists, all the faculties, all delegates, everyone to make this annual events because as a successful or much awaited event in the sense that we try to bring the positive trials of the protocols or the algorithm which can be help us in the practice or which are sort of the new breakthrough. And I request my colleague, Dr. J.B. Sharma, medical oncologist from Delhi, to conclude this 2 days meeting. Over to you, Dr. J.B.
So thank you, Dr. Naresh, and thank you all the participants. Thank you all the delegates. Thank you all the DNB students who have participated in the quiz. And congratulations to all the three students who have succeeded in this quiz. And academic partners, thank you, Freshness, Kavi, Rose, GSK, AstraZeneca, Glenmark, Intouch Oncology, Dr. Reddy's, and Hetero Healthcare Limited. Most importantly, thank you all the technical staff who has very effectively managed this conference. And thank you, Pooja. Thank you, other partners also. Thank you very much. And the main important is Mr. Tarunji. Thank you very much. Pooja, thank you. And all the participants. And most importantly, thank you, Ankur Shah, and thank you, Ananya, for conducting the quiz very effectively. And thank you, everyone. Thank you very much.
Thank you, Naresh sir and JB Sharma sir,
Naresh
for the
ji,
opportunity.
Thank you so much for the
yes,
opportunity.
yes,
Thank you.
thank you.
Thank you, Dr. Naresh Somani
Thanks,
sir.
everyone. Thank
Thank you,
you.
Dr. J.B. Sharma sir. Thank you, everyone who has taken pains to conduct the quiz. Thanks to the winners and congratulations to all the winners. We'll be reaching them out. And thanks to my colleague Pooja, Manya, Daud, entire Horizon team. Thanks, technical support. Good night, everyone. Stay safe.